or peculiar your thoughts are, you
Okay, good morning, everyone. My name is Marilyn Walsh. I'm a director with the Canadian Spondylitis Association. I've been a volunteer for 8 years, and I've run a support group in Hamilton, Ontario for the past 7 years, and I'm currently sitting on the National Board of Directors. I'm your MC for the morning, and I would like to welcome all of you on behalf of myself, the Canadian Spondylitis Association, and my partner and director here, Gloria Boudreau from Halifax. I would also like to say a huge thank you and welcome to our guest speakers today. We have Dr. Volodko Bakowsky, a rheumatologist, physiotherapist Susan Parlee, psychologist Dr. Dayna Lee-Baggley, and we have our guest speaker, Christopher. Next slide, please. Okay, and it goes without saying that events like this would not be possible without the generous support of our many partners. For that reason, we would like to thank and acknowledge AbbVie Canada, UCB Canada, Eli Lilly Canada, Novartis Canada, Merck Canada, Amgen Canada, Pfizer Canada, and Janssen Canada. For those of you unfamiliar with the Canadian Spondylitis Association, I'd like to tell you that we are the only national organization that has the sole purpose of supporting individuals and who live with different forms of spondyloarthritis, as well as their loved ones. When we talk about spondyloarthritis, we include all forms, including ankylosing spondylitis, psoriatic arthritis, enteropathic arthritis, reactive arthritis, undifferentiated spondyloarthritis, and juvenile onset arthritis. We are also nationally incorporated as a not-for-profit organization since 2008, and with the exception of our executive director, we are comprised entirely of volunteers who either live with or who are affected by some form of spondyloarthritis. We have 12 members on our board, and we also have other volunteers who help with our communications team and help with support groups around the country. A little housekeeping to begin with. You will find on your seats you had an evaluation form. We would ask that you all please fill them out and leave them on your seats when you leave today. We'd like to know what was successful and what would like to see improvements in for the day. Okay, we'll get them. Okay. And also, you will find a little card or piece of paper on your seats, and that is to write any questions that you might have for our question and answer session later on at the end of the day. And we would ask that you hold all questions till the end of the day. And for those of you who are joining us by a webinar today, we would ask that you please send in your questions via email to questions@spondylitis.ca. We would ask that you please turn off all your mobile devices or put them on vibrate so that we do not interrupt any of our presenters, and also in consideration for everyone else in attendance. Washrooms for anyone who needs them are across the hall from us in the wall painted orange. Refreshments are at the back of the room, so please help yourself. And please, anytime during the session, feel free to stand up and move around. And that brings us to our agenda for today. We have a wonderful array of speakers today, and our first is Dr. Volodko Bakowsky. Dr. Bakowsky grew up in Thunder Bay, Ontario, went to Queen's University in Kingston, Ontario for medical school. He does his residencies in internal medicine, followed by rheumatology at Dalhousie University, practicing rheumatologist for 18 years with the Division of Rheumatology at the Queen Elizabeth II Health Sciences Centre, and is an associate professor of medicine at Dalhousie University. And Dr. Bakowsky will be speaking us today about the disease overview of spondyloarthritis, updates on medical treatments, and what's new and on the horizon. Please join me in welcoming Dr. Bakowsky. Thank you.
Okay. Well, all right. Thanks for the invitation, everybody. This is being videoed, so I get to use I have a great face for a radio joke, which is unfortunately true. I like doing these things because they sort of, remind me of why I do my job, besides to pay the bills. But it's always refreshing to see people in a natural environment, not in the formal setting of my clinic. So, anyways, I appreciate the opportunity. I had 45 minutes of slides, which I had. I always err on the side of too little, because too little is better than too much. And I wasn't sort of advised that it's now down to 30 minutes, so I'm going to have to cut and slash a little bit, so my apologies. Good thing I'm not an anxious person. But anyways, basically, I have to explain what I am to a lot of people. You may know this, but we have this name, rheumatologist, and the origin of that is from Greek. Rheum meant flow, and back in the old days, they thought disease was caused by abnormal flow of one of these four humors, and so they thought arthritis was related to that problem, right? So nowadays it's sort of almost a meaningless term, and I think we need to change the name. But I would love to be a firefighter. I could be on a calendar. I could lift weights during the day, get fit. But modern day rheumatologists, we're kind of like immune system firefighters. If there's a problem over here, we put that fire out. We don't have to climb ladders. So. Anyways, so rheumatologists also suffer from low self-esteem, and we feel like we're, going to be exposed as a fraud at any moment. It's called the imposter syndrome. I'm glad we have a psychologist here. She's going to help me out later. But anyway, so this is a cartoon about that. Your fear of being publicly exposed as a fraud is a stress-related disorder called imposter syndrome. It's common among people in high-profile authority positions, and of course in actual phonies like you. So by the end, you'll decide which group I'm in, because I'm not really sure. So I have a few slides that just set the stage of arthritis. Sometimes I give these talks, and everybody in the group has some other condition, right? So I usually preface it with just some background slides. And arthritis is a term. We overuse it, right? The Arthritis Society says there are 100 types of arthritis, and I think, really? I don't know 100, but no one's called me on it yet. But in any event, I think this group looks very smart and very schooled on this. So in any event, there's, some of the things we call arthritis are things like, tendon problems and low back pain, et cetera. It's a very broad group. So, and then to set the stage as well, there are, two main categories of arthritis. There's degenerative, or things are wearing out, and then there's inflammatory. And so degenerative is basically osteoarthritis, which is a very huge public health problem. And then there's inflammatory problems, which, they're manifested by, prolonged stiffness, heat in the joints, swelling in the joints. So I'm just going to skip over some of these in the interest of time. This is just basically a normal joint. It's nice and healthy. And this thing that's actually a section of a joint. And it's really beautiful, right? There are things everyday life, you just say, oh my God, that's beautiful. It surrounds us. There's a shirt there, kindness looks amazing. That's beautiful too. So basically, this is a joint, and you can see this is the bone, and this is the cap of cartilage. And everything's just really hunky-dory. That's what I'm fortunate enough to have in my hands, for example. And then in osteoarthritis, you get, the joint just starts to deteriorate. And I'll show a section there. You can see in osteoarthritis, look, the cartilage is gone there. It's still present here. And then you see this kind of bony growth here. That's an osteoarthritic joint. and that's what they kind of look like, right? So people, when I'm trying to untangle, family history and things like that, people will say, grandma had rheumatoid arthritis, great-grandma had rheumatoid arthritis, my sister has rheumatoid arthritis, my mailman has rheumatoid arthritis. I say, well, do they have knobby knuckles? Are they just bony? And so that's a way to sort out whether they have osteoarthritis. Okay. So inflammatory arthritis are another sort of branch of the whole group of under arthritis. And you can have an infection in your joint, like Staph aureus. I don't recommend it. It's very dangerous. You need surgery right away. You can have crystalline arthritis. That's arthritis that's caused, for example, gout is caused by uric acid crystals. And then you can have also, some rare things as well, or rarer, that don't really fit. And then you're kind of left with two main categories. You can have rheumatoid, or you can have not rheumatoid. And so not rheumatoid is spondyloarthritis, which is the topic for today. That's why it gets its own special color. So in inflammatory arthritis, basically, here's the bone. You have the synovial lining, or the lining of the joint, becomes inflamed, and what's normally 1 or 2 cells thick is like 20 cells thick, and it secretes. It's like when you have a cold, your nose produces all that gunk and stuff. All that gunk gets in the joint lining, and it's full of enzymes that eat away cartilage and eat away bone. So you can see that the cartilage is lost here, and it actually eats into the bone. And that's what happens in inflammatory arthritis. So here's a section of a joint that has inflammatory arthritis. This is the cartilage cap. And then all this stuff, that's all the synovial membrane, the membrane in the joint. And it looks horrible, doesn't it? I mean, it doesn't look anything like that beautiful hand that I showed you earlier. So this is a slide I made 100 years ago when I started practice. I took a highlighter and I colored. It's very low tech now. In any event, so rheumatoid arthritis, it really it's very symmetrical. It affects multiple joints. And so that's a kind of a rheumatoid arthritis pattern. If somebody walks in and that's what they're demonstrating, I think of rheumatoid arthritis. Whereas in spondyloarthritis, it's more commonly asymmetrical. It's more commonly fewer joints. And sometimes it can affect a whole digit, like a whole finger or whole toe. And also, as you know, the spine is often involved. So I've colored in the spine, I've colored in the sacroiliac joints. This is asymmetrical. And so when I teach people, I say this is the here a joint, there a joint pattern. And then I go everywhere a joint. So here a joint, there a joint, everywhere a joint. Now, in spondyloarthritis, particularly psoriatic arthritis, you can often have a rheumatoid arthritis pattern or a polyarticular pattern. So it's nothing in medicine, or very few things in medicine are an always thing, right? But if I see somebody like that early on, that's probably spondyloarthritis, probably not rheumatoid arthritis. So this spondyloarthritis group, we used to split them all up. And then it was hard to remember because they all kind of looked and sounded the same. So now we're kind of more lumpy, and for a variety of reasons. I'm older, I'm lumpier, but also because they're more similar than they are different. And this group of disorders share certain features, like the fact that a whole finger or a whole toe can become inflamed, which we call dactylitis. They all can affect the DIP joints, these ones here, which in rheumatoid or other types of arthritis other than osteoarthritis doesn't tend to affect those joints. Enthesitis, that's inflammation where tendons and ligaments attach to bone. So commonly people with spondyloarthritis might have Achilles tendonitis, they might have plantar fasciitis or pain in the bottom of their heel. And those are common things in other people, but in other people they're a degenerative process. They've started running the training for the half marathon or something, and the tendon's just unhappy. But in spondyloarthritis, there's actually disease and there's actually inflammation in those places. The spine can often be involved, right? In ankylosing spondylitis, by definition, the spine is involved. You can get eye inflammation, iritis or uveitis. And very commonly, there's an association with this wonky gene known as HLA-B27. So those are shared among all those diseases. And here's an image of somebody with psoriatic arthritis. You can see the nails have changes, right? They almost look like they have a fungal infection, but they don't. It's the nail changes of psoriasis. You see some patches of psoriasis here and there. And the DIP joints are involved. And let's see, this finger too has got dactylitis. The whole finger is swollen. And it's probably shortened a little bit too, because you can actually get bone resorption in these diseases. And here's somebody with a lot of bone resorption. You can see that just the reaction to the inflammation causes bone to be resorbed. And we call that opera glass hand, because in the old days people had a telescope to watch the opera, and then when they were done they could squeeze it together. And so that's a feature of, so if you x-ray somebody like this, it's almost as if, you know, they put the bone into a pencil sharpener and whatnot. But in any event, hopefully nobody's like that here. And here's just another image of psoriatic arthritis. You can see this toe. We also call it sausage toe, which will turn you all into herbivores, because it's sort of like when you barbecue a sausage and it plumps up like that. And here's an image of Achilles tendonitis. So this is a normal Achilles over here, and this one's all puffy and inflamed. And if any of you have had Achilles tendonitis problems, it's like the last place to get better, right? You know, everybody, the whole person's better, but this is just it's like the last foothold of the disease. It's very frustrating sometimes. And as you know, you can get spinal involvement, which will cause spinal stiffness, and this person is bending, but basically all the bending is happening at the hips, and this is just flatter than flat. And this is an x-ray of the sacroiliac joint. So the lower part of your spine is called your sacrum. It's 5 bones that are fused together naturally. This is your pelvis. And you have these little joints, these joints here called the sacroiliac joints. And they don't move a whole lot except in labor and things, and then they probably move a whole lot then. But you could see that when on this x-ray, the bone here is probably whiter than it should be. And the joint margin, it's quite irregular, like it's hard to see. I've got a tremor, oh my goodness. So this is the hip joint. You can see a nice smooth joint margin. Here it's kind of irregular, and the inflammation actually kind of chews up those joints, and eventually you could get bone production and they can get fused. But so SI joint pain is often felt in the buttock, right, the upper buttock. And here's some x-rays of the spine. So early on, you know, there's subtle, so this is a kind of a normal shape. It kind of has a loop-de-la-loop. And early on, you can just get squaring of the vertebral bodies, because the response to inflammation is to produce new bone. And so that's a very early change. And here's a late change where bone is actually grown right across the disc space. We call that a bamboo spine. So, during the introduction, a bunch of diseases were listed. And this is kind of, you know, the classical thinking. So there's ankylosing spondylitis. So by definition, you have to have abnormal SI joint x-rays to call somebody ankylosing spondylitis. So you can have the same disease, but you can only see changes on MRI, and technically you can't call that ankylosing spondylitis. So it's just a problem with how we name things. It's the same disease, but when ankylosing spondylitis was named, we didn't have MRI, for example, right? And then psoriatic arthritis, you have to have psoriasis. Inflammatory bowel disease associated arthritis, you have to have inflammatory bowel disease. Reactive arthritis is fairly rare, but it can occur after, you know, gastroenteritis from food poisoning or a chlamydia infection, believe it or not. And then if there's none of the above, we call it undifferentiated. So that's sort of the classic thinking of these diseases, but it starts to fall apart, right? Because say you have somebody who you say has ankylosing spondylitis, and then 10 years later they get psoriasis. Do you change the name? Like, what do you do? Does it matter? These are all existential questions that I do not have the answer to. But kind of a newer way of thinking of it is to just say this is spondyloarthritis, and is there spinal involvement? And we say axial because we have to use big words or more complicated words. And then is it peripheral joint involvement, or is it both? And then do they have associated problems like psoriasis, inflammatory bowel disease, IBD? And so that's sort of a more inclusive way, or kind of a more modern way to think about it. So spinal disease, peripheral disease, both, and what other associated features do they have? So as far as treatment goes, we're supposed to educate you. I think because of time, we probably do far less education than we should. I tell people, go to the internet, there's good information there, and I hope they find it. But exercise. So if you have spinal arthritis, exercise is a key component to your therapy. And it's not like other people who can exercise, 3 or 4 times a week. It's an unforgiving condition. You gotta do it all the time, right? If you never stopped and you didn't sleep and you just kept walking around, and you'd be better off. But of course, that's completely impossible. And then chronic disease management. People often ask, what if I eat turmeric, or what if I do this? And my mama taught me nothing in life is simple or easy. And so I just tell people, look, you have a chronic disease, you need to look after yourself as best you can in every other way. And whether that's, psychologically, with diet, I say eat a lot of plants and make things yourself. If it comes in a box, it's probably not as good as if you made it yourself. So that's my philosophy. I mean, when people ask me, what about this thing? I usually go, when I have time, I go to the internet and I do a search and I go through things. Oftentimes there's not a lot of information either way, and I just say, look, if it's not dangerous and you do that and you feel better, great. But it's not something I recommend to everybody eat turmeric or don't eat turmeric or whatnot. So local therapy. So local therapy would include things like heat and ice, et cetera, et cetera. We have colleagues in physiotherapy you're gonna hear from, and occupational therapy, and then medications, which is what I do, and also surgery, right? Surgery can help, but when you're at the time for surgery, it's kind of like you're at the end of the line. It's to some degree a failure of medical management, but they can really help a great deal, and really have a huge impact if and when that time comes. So how am I doing for time? Doing well? Oh, good. So medications, I put exercise on there again, and that's not a typo. I think exercise is a drug, and we all should be on it, whether you have spondylitis or not. And if they could put exercise in a pill, I would want that pill myself, right? So then there's non-steroidal anti-inflammatories. Those are medications like naproxen or ibuprofen. And if you have a peripheral joint arthritis, they make people feel better, but they don't really fix anything. For people with peripheral joint involvement, I don't really push anti-inflammatories that strongly, because you don't get a medal for suffering, but it's their life. It's not a huge change either way. However, when you have spinal arthritis from spondyloarthritis, anti-inflammatories are often almost like miracle products. They're often the difference between nearly fully functional and being in rough shape. And so for the spinal arthritis, anti-inflammatories really are the first line medical management. And I tell people, look, the treatment's exercise. If you're too sore to exercise, you need to be on anti-inflammatories, right? But they also don't alter the natural history. They don't prevent spinal fusion, but they're often very helpful drugs. And then there are these traditional disease-modifying medications. Those are drugs that, reduce joint damage. They make disability on average lower. So these are sort of drugs that are kind of preventative, but they don't really work at all for the spinal arthritis. So if you have psoriatic arthritis and you have peripheral joint involvement, these are the types of drugs we put people on, drugs like methotrexate, leflunomide, sulfasalazine. But again, they have no effect on the spinal arthritis. There are some newer agents for psoriatic arthritis. There's a new oral drug called apremilast, and there are some new ones just recently in the New England Journal. There was a couple articles on a new oral drug, tofacitinib, for the treatment of psoriasis and psoriatic arthritis. But again, as far as I know, I've not seen any data to suggest it's helpful in the spinal arthritis, although, you know, stay tuned. I think they're looking in that area. Then we get to these biologic agents. So a biologic, where does that name come from? Well, it comes from the fact that these are taking naturally occurring messengers in our bodies and utilizing these naturally occurring messengers to try to target and treat disease. So people think of them as, you know, smart bombs. I think any bomb's a stupid bomb, but in any event, it's very, people also call it targeted therapy because it has, rather than we give it to people and it seems to work and we have no idea how it works, you know, we kind of have an idea how these work. They're also called biologics. They're actually grown in a biologic system. So they're grown in bacteria or some type of cell culture. Doesn't that make you want to take them? Anyway, so I guess, yeah. So basically the premise of this, so if we have an immune cell and you have another immune cell and they want to talk to each other, you know, this immune cell can secrete a substance and it can float along, and then if it binds to a receptor on the second cell, it can give a signal to, like, hey, you know, drink coffee and you know, get your act in gear where we've got some inflammation to cause, right? So that's the sort of the mechanism of a cytokine or chemical messenger. Sometimes there are some messengers that when they bind, they say, calm down, relax, you've done a lot, just take it easy. Don't, you know, that inflammation that occurred, you know, you should just try to relax a little bit and make it go away type of thing. So you can have positive signals, you can have negative signals. Now, this is, there's a test at the end, and so, you know, these are, you know, immune cells, and these are all these different cytokines, and, you know, there are smart people in this world, and they're studying this, and I'm glad that they're studying it. And to some degree, you know, you have this this web of communications, right? And it's a bit like, you know, I was thinking on my way here when I was a kid, and I dialed 0, it was a rotary phone. You know, I got a human, and they said, well, you know, what do you want to do? It was reverse the charges or something, right? But even probably before that, there were people, and I suspect they were women. I think I'm envisioning, what's that, admin or that? Yeah, anyways, so there was, you know, if you put the jack here, you could, a switchboard, yeah, exactly. So it's almost like, you know, you have to knock out a certain one of these lines and then hope that that actually improves the disease, right? So if they had asked me, I would have said, well, there's no point because look at all these pathways. You're blocking one thing, like that's not going to work, but it works. So it's a good thing they didn't ask me. So there's some fortunate things in this world. So if I use TNF inhibitors only because they were kind of the first that came out. And so if you have the macrophage is a type of immune cell, it secretes TNF alpha, which is this cytokine receptor. It sort of diffuses across the space and binds to a TNF receptor on another cell, and it stimulates that cell. So what a biologic will do, either you make an antibody that you inject or infuse into the circulation. It can mop up this extra TNF and take it away so it's not stimulating that cell. Or some of the drugs are actually this receptor, but instead of it being bound to the membrane, you're just injecting extra receptor that mops up this extra TNF alpha. So the same principle applies no matter what the biologic is. You could change it around to. So the biologics for spondyloarthritis and psoriatic arthritis, they include these TNF inhibitors, which were the first ones. And there are 5, quite a lot of them now. And there's also now biosimilars. Has anybody heard of that term, biosimilars? It's basically the drug has been, are you standing because you need to or because I'm late?
No, because I need to.
Okay, all right. You should see a doctor or get a better one. So So the biosimilars, so the drugs have been around so long that they're now off patent. And so now people can make basically generic versions of them. But because they're made in cells and bacteria, they can't call them generics, they're called biosimilars. So this is good because it's going to hopefully reduce the costs, drive the costs down. And in all the studies, they work exactly the same. So that's what a biosimilar is. And then, I thought there are some other biologics. I thought I changed something, but anyways, there are other biologics too. There is an IL-12/23 inhibitor. That's called ustekinumab or Stelara. There is a IL-17 inhibitor called secukinumab or Cosentyx, and there are more of those coming. And there's also, so in IL-12 and 23, people have figured out that it's more the 23 that's important, so there are a bunch of IL-23 inhibitors coming. So the armamentarium is expanding to other kind of cytokines, and when one is discovered to be helpful, you know, each company or they'll often make their own as well. So whenever there's a promising avenue, there's a bandwagon that the companies jump on, and so there are going to be several versions of that targeting. So the field is expanding to beyond TNF inhibitors is the bottom line. So what are the pros and the cons of these biologics? Well, the pros, I think number one is that they can be very effective. Another pro is that they work quickly, right? So people often, sometimes with the first treatment will say, oh my God, it worked right away. You're not, you know, twiddling your thumbs for months and months trying to figure out if it's going to work. And they're generally well tolerated. I mean, when you read about them, they sound scary, but people, you know, they don't make people feel yucky usually. So that's good. The cons, number one, the cost. They're ridiculously way too expensive, and that's, I think, the biggest con. They're injections, and if you've never injected something, that's a big step, right? And then, you know, the main potential risk is infection. And I quote people about a 2.5% risk of a serious infection per year. So, you know, that's the biggest concern. So, everything in life always has a, you know, a good and a bad, and it's just the proportion of each. So, in treating axial disease, so that's the spinal inflammation, really you kind of have physical activity, and then add an NSAID if needed, a non-steroidal anti-inflammatory. If that's not good enough, you could switch the anti-inflammatory. Is that going to work? Nah, but the insurance companies usually want to know that you've been on two, because they're all kind of the same. One's a Ford F-150, one's a Dodge Ram. So, and then if the anti-inflammatory isn't working, then you have to go, the next step is a biologic, really. There's nothing in the middle, right? It's mind-boggling. You go from, you know, a $20 a month anti-inflammatory to a ridiculously expensive drug, but there really is nothing in between. So, I think in my hurry, I screwed up. I made an error. That was the slide I thought was coming, but I've already stumbled through it. So that's good. So, so in summary, you know, these are a common bunch of disorders, right? So rheumatoid arthritis gets a lot more, you know, public attention, I think. People say, you know, 2% of the population has it. I think that's perhaps a slight overestimate. But if you add up psoriatic arthritis, ankylosing spondylitis, you add those all up, it's as common as rheumatoid arthritis, maybe even more common. There was a bullet earlier in the introduction that said I was going to explain the cause. So I can try to explain the cause. So there is a genetic component to psoriasis and psoriatic arthritis. There's a very strong genetic component to ankylosing spondylitis that's associated with that HLA-B27 gene. But beyond that, we don't know, really. We don't know the cause. There are especially in ankylosing spondylitis, you know, people wonder, is it somehow, you know, a gut flora? So that's a polite way of saying the bacteria in your intestines. But really, we don't really know. And sometimes people, you know, they rack their brains and they're trying to figure out cause and effect. And I just say, look, you'll drive yourself crazy. We just really don't know. I would tell you if I knew, but I don't. So you can't change your genes, and you can't change what you don't know. So, and all these diseases, they have many shared both musculoskeletal features and shared non-musculoskeletal features like the iritis, for example. And there's lots of potential treatments, but they need to be, you know, tailored. They need to be tailored to your unique situation, depending on what kind of disease manifestations you have. And obviously, you know, your own personal values, right? You know, we try to make good decisions in this world. There are very few people that intentionally make bad decisions. I don't think anybody does that. I've gone the whole day without a Donald Trump joke, and maybe he's the exception to the rule of trying to make bad decisions. But, you know, it's a personal decision about what medication to take. And you know, a lot goes into that, and it has to be what's right for that individual patient. So I hope I never push anybody into doing something that they're not kind of ready to do. And I figure I'm just an advisor on this journey, and I'll tell you the options, the pros and the cons, but the final decision is always yours. So in any event, and so I had...
We're going to leave the questions to the end to everybody.
Okay, sounds good. So I'm done then. Thanks very much.
Sending in questions.
Okay, just to let anyone know who's sending on questions online, we will be having our question and answer session at the end. So please hold on for that. You can send in your questions, but they won't be getting answered until the end of this session. I'd like to thank Dr. Bakowsky very much for that, not only comprehensive, but very comprehensible presentation. I truly appreciated the plain language. And I'd now like to welcome Susan Parlee, a physiotherapist, who's going to do our next presentation. Susan graduated with her degree from Dalhousie University School of Physiotherapy in 1987. After working at the General Hospital in New Brunswick for a few years, she returned to Halifax and began working at the Nova Scotia Rehabilitation Centre with clients with musculoskeletal conditions. Approximately 10 years ago, she began to further her education in rheumatology. Her area of interest and her focus of practice more specifically on this field. She continues to enjoy the opportunity to work with these clients. And we are very thrilled to have you here today, Susan. I'm going to switch places with you here.
All right.
Thank you.
So before we get started, everybody stand up, for heaven's sakes. You've been sitting for too long.
Yes.
So if you want to stand, walk around, like, don't worry about it. I'm fine with that. I think it's good and healthy, so let's get going. Okay, so the non-pharmacological management of spondylitis. So physical activity and exercise guidelines. So as I said, as the slide says, they are guidelines, so we'll go bit by bit. So exercise and arthritis. It's been said that exercise is the single most important thing you can do to help yourself. Exercise leads to improved flexibility and fitness, better health, and improved quality of life. And really, when it comes down to it, quality of life is the main thing that we're all looking for. As Dr. Bakowsky has said, medication alone is not enough. So people, I don't always like to use the term exercise because it scares a lot of people. They think exercise means going to the gym and working out and that type of thing, but it's activity, it's movement, and the broad term and what helps the most is the amount of activity you do. So activity is defined as energetic action or movement or liveliness. Exercise is a very specific activity that is performed to develop or maintain a fitness or a skill or good posture. So we'll go into, we'll do the general activity things and then talk a little bit about specific types of exercise. So with general physical activity / exercise, the health benefits are huge. So when this talks about regular exercise and these percentages, this is if you're meeting this, the national guidelines. So it's approximate 25 to 30% reduction in the risk of developing chronic diseases such as diabetes, high blood pressure, heart disease. Approximately 25 to 30% reduction in the risk of developing a stroke, colon cancer, breast cancer. About a 40% reduction in the risk of developing Alzheimer's. Exercise has also been shown to decrease depression as effectively as use of medications or cognitive behavior therapy. And the big thing is that the overall risk of dying early is reduced by about 31%. So that's for the general population, for everybody. Other types of benefits that you get, of course, are the increased flexibility, and these are the types of things that really can affect your arthritis more, affected more specifically. So you're increasing flexibility, your range of movement, your posture, your sleep, and your overall reduction in stiffness and pain. So the Canadian Physical Activity Guidelines, that's the old participation people, they state that 150 minutes per week of moderate to vigorous physical activity in bouts of 10 minutes or more. So that 150 minutes can be broken up, like it says, in bouts of 10 minutes. So in less than that, everything you do counts. Anything less than that, the benefits aren't as obvious, I guess. So when you can do 10 minutes continuously, you start to reap more of the benefits. Also, 2 days a week of resistant exercises can be helpful. So the 150 minutes a week, if you spread that out over the week, if you do 100 minutes one day and 50 minutes the next day, then you get, the other 5 days you've got nothing. It's not quite as good as spreading it out and doing a little bit every day. So it can work out to 30 minutes 5 days a week, or 21 minutes 7 days a week, and that'll get you to the guidelines. Another way people look at it sometimes is they do the steps per day. It's the same, works out to be the same type of thing. Your 10,000 steps a day, or walking your 8 kilometers a day. So these guidelines do apply to everyone, regardless of age or whether you have a chronic disease such as arthritis. Moderate to vigorous intensity. So this is where, somebody who's 18 versus somebody who's 75, the guidelines are the same. They're probably not going to be able to do the same type of exercise. But because it goes by heart rate, breathing rate, and perceived exertion, somebody who's older can still get to these levels in their own body. So increase your heart rate to about 60 to 80% of its maximum. That's where you get your cardiovascular effects from. It also will increase your breathing rate, which is a nice way to monitor these things. So this is the rate of perceived exertion chart. So you mostly want to be somewhere in the greens and the yellows, maybe that first orange. So, the fella at the bottom, they're level 1. You're watching TV and eating candy. Well, that's really not the level of exertion you might want to go for. But it start to get up to 4. You're sweating a little bit, still feel good, and can carry on a conversation comfortably. Level 5, as I'm just above comfortable, I'm sweating a bit more, and I can talk easily. So those are, that's starting to get the heart rate up a little bit. Level 6, I can still talk, but I'm slightly breathless and definitely sweating. 7, I can still talk, but I don't really want to, and I'm sweating like a pig. So Heart and Stroke Foundation uses the talk test, which is very similar. The talk test says that you should be able to speak a full sentence when you're exercising. So if you start to gasp between So the types of activity. So for general exercise, general activity, low impact is recommended. Anything high impact like running, jumping, football, anything like that, not really the best sport to decide to take up for when you have spondyloarthritis. Aquatic exercise is the most widely recommended type of exercise. So swimming itself, or water aerobics or any sort of activity in the water. It reduces, of course, all of the strain on the joints. The water itself provides resistance. It works on balance, works core strength. It works just about everything. So I put in a little tip about the snorkel. If you like to swim, but then too much stiffness in your neck to turn your head, a snorkel can work. Walking, I love, to tell people walking is a wonderful exercise because it's very inexpensive. It is important, however, to have the good footwear. Things like using the walking poles, you see people going with those. They're fantastic. They give you a core workout. You work your arm muscles as well as your leg muscles, so you're working 95% of the muscles in your body, and you basically burn more calories that way. So same amount of time, a little more bang for your buck. Bicycling or stationary cycling, anything like that. Somebody who's, with the low handlebars and you're all bent over, it is hard on the upper back and the neck. So the higher handlebars, a little bit of help because they do allow you to stay in a more upright position. Other things, dancing, badminton, volleyball, getting an elliptical. There's all sorts of things that you can do. The number one rule, of course, is that you have to enjoy it. If you don't enjoy what you're doing, you're not going to keep it up. So find something you like to do. Find somebody else to exercise with you. It's much easier if your neighbor's expecting you to knock on the door in the evening to go for your walk. So if you are not exercising currently and you are thinking about starting a new exercise regime, it is a good idea to get some advice from your healthcare team if you have another major medical condition such as heart problems or high blood pressure, if you have had a recent major surgery, if you're pregnant, or if you are having a flare at the time. And I'll talk a little bit more about having a flare later on. So the usual disclaimer, if you experience chest pain, dizziness, if you faint, or any types of those things while you're exercising, then perhaps calling 911 would be helpful. Always start slowly. So if somebody comes to me and says, well, I'm going to start a walking program, or I'm going to start doing this, what should I do? I just look at them and say, well, how much do you think you can walk? How far do you think you can go? They say, oh, I can walk 20 minutes. I say, start with 10 and just do 10 minutes and build up from there, build slowly. There's no sense in going in too fast and then end up not being able to do it or getting frustrated because you can't do what you think you want to do. So these specific exercises for spondylitis, those, the general ones, you got to do those every day. The specific ones improve and maintain your posture, your range of motion in your joint and your spine, your muscle length, muscle strength, the chest expansion, which keeps your lung capacity at maximum, working your balance. We've already talked about the cardiovascular fitness. So the specific exercises, there are some in the booklets, and they're fabulous. Certainly if you have other problems, you may need some very specific ones yourself, something slightly different. So if you're having an area that, if you've got a really stiff hip joint, you might need some more specific exercises for there, then certainly that's where we come in. So posture itself, we'll talk about because it is one of the mainstays. So posture, it is crucial, it's absolutely necessary that you try to maintain good posture all the time. If your spine does happen to get into that bamboo spine, that fusion level, it's much better to be upright. So posture, everybody thinks posture, stand up straight and that's it. But posture really means it's your alignment no matter what you're doing. Whether you're dancing a jig or you're standing on your head in the corner, sitting, standing, whatever, it doesn't matter. Posture is your alignment, and it's really important that you maintain that good alignment at all times. So proper alignment, so it would be the guy in the middle. Most people is either the guy on the far side or this, for the one on the left here, we'll see, you tend to see that a little bit more with spondylitis types of things. But with good posture, you're basically, your ear is aligned over your shoulder, shoulder over your hip, hip over your knee. So if we're going to correct our posture, so let's everybody stand up. Oh. Got it. So the first thing when you're talking about posture is never lock your knees. So if your knees are locked, you cannot correct it. So first thing, you give your knees a little wiggle. They don't have to be bent, but just a little bit loose. So you unlock the knees. Then the rest of it, 85, 90% of it, you bring the chest up. So once you bring that breastbone up, the neck generally aligns quite nicely. Just make sure that when you do, think good posture, I get everybody, they go, oh yes, here I have good posture. Well, now they're looking at the ceiling and their neck's in extension. So chin's tucked just ever so slightly. So that does most of it. Most people, again, now need a little bit extra at the shoulders, so there's a little slight roll back of the shoulders. So what you should feel are the muscles between the shoulder blades, a little bit of tightening in the lower tummy. That helps to keep you in the good position. So now, from this, you relax 10% so that when you go to move, you can still feel fluid. It shouldn't be a rigid posture. But keeping that alignment throughout your activities is really important. All right, sit back down because we're going to talk about sitting posture. Okay, so sitting posture. So when you sit, first thing you do is you get your backside back into the chair as far as you can. So from there, then you may need to add, depending on the chair, depending on the shape of your spine, you may need to add a little bit of a roll or a cushion or something in the lower back. As you can see in most of this, you don't really want to let your spine get into that rounded C shape. The normal spine is lined up with a slight S-shaped curve, if you look from the side. Anything that rounds it is not good, not the way you want to be. So especially if you're sitting in the chair, like if you're on your computer and you're leaning forward into it, you've got to switch the computer setup or something so that you can sit upright. So you think of your rule of 90 degrees. If you're sitting down, your hips are at 90 degrees, your knees are at 90 degrees, feet are flat on the floor. If you're on the computer, your elbows should be at 90 degrees. So that if you're using a keyboard, mouse, everything you're using should be in this little swing space here. So it's not far away from you. The minute you have to reach for something, you're going to be in trouble again. Now, if you're somebody like myself who's not overly tall, let's grab a chair here. So sometimes what happens if I sit in a chair and I go all the way back, like it's just digging into my knees, or worse, sometimes if I'm on a sofa, my feet will be out straight. So what I would do there is I would get back as far as I comfortably could, fill in the space with a cushion or a throw pillow or something that shortens this up for me, so then I can sit comfortably. If I still can't reach the floor well, I put something under my feet. So telephone book is a wonderful thing, and it's a great time of year because the new phone books just come out, so you can use your old phone book. They make wonderful little footstools. They also make good footstools if you have to stand for long periods, because standing with your foot up helps keep you lined up. You can't get into that bad posture if you're standing with your foot up. So keeping in mind those things like, what's my alignment? Can I keep upright, keep things close to you? The minute you reach away, then you're in a little bit more trouble. So I could probably talk for an hour on total body mechanics, but it might be a whole other session. So people will ask about reclined positions. I think there was a study that came out, it was in the paper a few years ago, that sitting upright wasn't good for you and whatever. And yes, sitting in a reclined position does unload the spine, and it's a good position for the spine, but it's not very useful. So the next best position for sitting was sitting up. So if you're reclined, people say, what about my lazy boy? I like my lazy boy. And they're generally fine because you can recline. However, I do find a lot of times they're very soft, they're old, and you tend to sink into it. So then you're into that C-shaped curve again. So just as long as you're supported and your head's not shoved forward too far, it's a nice relaxation position. That said, never sit for more than 20 minutes at a time. Sitting is the new smoking, because when you sit for 20 minutes, there's a lot of force on the spine, and it does need to be relieved at that point. The joints do start to stiffen, and every one of you in this room probably knows that after 20 minutes. And the other thing is metabolism starts to slow down. Circulation slows down in 20 minutes. Your body's going into like hibernation mode. So keeping moving, no matter what you're doing, if you work on a computer all day, Set a timer every 20 minutes, get up, walk around the chair, sit back down. It will help. The studies show too that people who move frequently through the day are much healthier overall than somebody who sits for 8 hours a day at a computer and then does their 150 minutes a week of exercise. They're still not as healthy as the guy who can move around all day and move frequently through the day. All right, so these specific exercises, as we said before, they're important to maintain flexibility. So when you hear talking about body mechanics and lifting and all of those good things, it's always so keep your spine still, don't move your spine, don't move your spine. But it is important that we are able to move our spine. We should still have the ability to move and go through range. So in the spine itself, there are three parts. You've got to think about the neck, the upper back, and the lower back. The rib cage, I find people don't think about this one often enough. Now, if you're doing a lot of aerobic activity and you're doing a lot of deep breathing that way, that can certainly help. But because of the joints in the front and in the back, they can get inflamed. The rib cage can get very stiff, and it leads to a decreased ability to fill the lungs up. So deep breathing exercises are usually quite helpful. In the shoulders, the shoulder joints are often affected, but the chest muscles often get very tight. So it's important to focus on those. In the hips, hip joints, again, are another target joint. The hamstring muscles are another muscle in the leg that often very, very tight. And certainly people have other joints that can sometimes be affected. So it's maintaining your flexibility in all of these areas. So you all have the little booklet. If you go to page 29, I love this booklet. It's a great one. So on page 29 is the first of the exercises that are in here, and these are, there's a number of them. They're great. They're very general, and for most people, they're probably fine, unless you're having a specific, you have a specific area that is stiff or maybe damaged, and you need to work a little bit more on it. So I'll just, talk quickly. That first exercise, the standing against the wall, if you think about that one, thanks. If you think about that one, you're starting, and you can do against the wall, because against the wall you tend not to cheat. And I also like the side one to do against the wall, because you don't cheat. So the first exercise, it does a lot of different things for you. So you're standing tall, you're practicing a good posture if you're against the wall. You're bringing the arms up, you're getting your shoulder range of motion. If you take a deep breath at the end of that, you're getting some rib cage expansion. So multiple things can be affected by most of these exercises. They're very simple, can be done through the day, in a chair, anywhere. Now, certainly, like I said, if you have an area that that you can't do a particular exercise, then you leave that one out to try something else. Okay. So the considerations that you want to take it. If you're just starting to work out, and especially if you're new at it, these things you may not have figured out yet, but planning your workouts or your routines can make a big difference. So, of course, early in the morning, then generally that's when most people are more stiff. A warm bath or shower can ease that stiffness a little bit beforehand. Be mindful of pain. Now, everybody knows the thing, no pain, no gain. Well, as a physiotherapist, I really hate that term. You should listen to your body. There's going to be some discomfort, and if I sent everybody to the gym and they did a whole new workout, they're going to be sore. Of course they are. But that's not the same as pain in your joint and pain from pushing something too far. So if the activity causes pain, or if your pain lasts for more than 2 hours after you finish your activity, you've probably overdone it. So if you do an exercise routine and you think, oh, my shoulder is killing me, and 3-4 hours later it's still killing you, then back off next time. You probably irritated something. So there's a fine line between too little and too much, and sometimes you have to really work quite hard to find that line. You want to avoid activities that do encourage poor posture, of course, so anything you're going to do for a long period of time, don't do it in a poor position. So now, while doing exercise will not cause a disease flare, if you are flared, you do need to modify somewhat. So some tips from Rheuminfo. They say that overuse of an actively inflamed joint may aggravate your arthritis, and it may increase joint damage. So this is, your swollen knee. If you do too much activity on that, you can increase all of those inflammatory changes. Using ice before and after can help a little bit, but again, you're still not going to push it during the flare. You continue your range of motion exercises. So let's say you've got a knee that's out to here. Your range of motion and your range is going to be limited, but you work in your comfort zone. You go up to the point of where it's painful, but not into that point. You do not push into pain. If you are doing a program, you might need to decrease the resistance or the weight that you're using and your repetitions for strengthening exercises. You don't stretch an inflamed joint. Again, that knee, if the knee is swollen, it cannot straighten fully. You don't force it into full straightening. It's important to get that straightening back as quickly as you can as it settles, but don't force it. If you're, doing walking is your regular routine and you're flared, walking can be very uncomfortable. You might want to then increase your pool exercises or cycling or something that's not causing any impact. You need to pace yourself. So with your activities, whether it's exercise or just your general activities, pacing yourself is very important when you're flared. Do a little bit, take a bit of a rest, do a bit, take a bit of a rest. Now, all the advice I gave, of course, is all very ideal. Real life kind of comes in there, so you do what you can do. And once your flare subsides, you gradually go back to your regular program. It does not take very long for muscles to start to lose strength. They get very inhibited when you're in a lot of pain, so it takes only a couple of weeks for you to see changes in muscle before you, so that to see the muscles change in a weaker condition, it takes at least 6 weeks then to build them back up. So, just start slow. All right, so if you have difficulty getting started, you don't know what to do if you've got like a problem area, that type of thing, that's kind of where our role comes in. People ask about, physiotherapy when you're first diagnosed and you come in and you think, I don't want to take any medication, can we have physiotherapy to fix my spine? Well, no, it doesn't work that way. Unfortunately, I have no magic that can manage those types of things. You need the medication to manage the inflammation. The physiotherapy can help you get going again, basically. But certainly, in Nova Scotia, you can see a physiotherapist by self-referral, or a physician can refer you privately or to the hospital, wherever you prefer to go. So, yeah, if you have any questions, we're always here, and we would like to be able to help you. All right.
Thanks for that very interesting presentation, Susan. And our next presenter is Dr. Dayna Lee-Baggley, a psychologist who is going to be discussing the emotional impact of chronic disease, something that I'm sure has impacted all of us at some point in our journeys. Dr. Lee-Baggley is a registered clinical psychologist. She holds an assistant professor appointment in the Department of Family Medicine and cross appointments in the Departments of Surgery and Psychology at Dalhousie University, and an adjunct professor appointment in the Department of Industrial and Organizational Psychology at St. Mary's University. She works as a clinical health psychologist at the Nova Scotia Health Authority Central Zone for the multi-organ transplant program, and as a trainer and researcher of the Behavior Change Institute. She has an active research program on behavior change, chronic disease, professional resiliency, and acceptance and commitment therapy. Dr. Lee-Baggley has over 35 peer-reviewed publications, and over 110 scholarly presentations. She was the recipient of the 2017 Woman of Excellence Award for her contributions to health, sport, and wellness from the Canadian Progress Club, Halifax, Cornwallis. And I'm just exhausted just reading that, absolutely exhausted. Thank you very much, and welcome to Dayna.
So that's supposed to make you think I'm an expert, right? But as we talked about earlier, it's actually making me feel more like an imposter, like you're going to figure out I really don't know what I'm talking about, but we'll give it a go. So we already talked about, my clinical position is with the Nova Scotia Health Authority, and I work with liver transplant patients and kidney transplant patients. I also work at the Behavior Change Institute, and we do training for staff on chronic disease management. So we work with nurses and physicians, physiotherapists, dietitians to help them better support patients in chronic disease management. So I'm a health psychologist, which means that people are referred to me not for mental health problems, but because they have a physical health problem. And so we're really working on the interplay between the sort of physical and emotional illness. So really, we have this distinction between like there's mental health and physical health. They're really the same thing, but we call them different things. So a health psychologist is looking at the whole person and how those two things interplay with each other. Okay, and it's about the promotion and maintenance of health behavior. So all of these recommendations that you've had about exercise and those kinds of things. Okay, so people who have a chronic disease are at a greater risk of having mental health concerns, such as depression or anxiety, compared to the general population. So there's a higher rate of mental health disorders. But what is more common is actually what we call chronic disease distress, which is distress about your chronic condition. So that's symptoms of depression or anxiety or other things that are about the fact that you have to manage this chronic disease, that if somehow you didn't have the chronic disease, you probably would be okay. And that's sort of a separate thing than having like major depressive disorder or an anxiety disorder, right? And you would actually treat them differently also, right? So the treatment for major depressive disorder would be different than the kinds of things that you would do for chronic disease distress, okay? So, you know, at the end here, you can have sort of enough distress that you're into a major mental health disorder. But there's all this part beforehand, which is just the distress of having to manage a chronic disease. Okay, so we actually have a measure that we use of chronic disease distress. And so asking about how much the disease is impacting your well-being. Okay, so things like feeling that my chronic condition is taking up too much of my mental and physical energy, feeling that my healthcare providers don't know enough about my chronic condition, feeling angry, scared, or depressed when I think about living with my chronic condition. So again, these are about the emotional impact, the emotional reaction of having a chronic condition. And there's different sort of areas of that. So there's the emotional burden of the disease, the regimen distress, so all of the things that you're supposed to be doing to try and stay healthy. Patient-provider distress, so difficulties with your healthcare providers, or social support distress, so people in your life, for example, not understanding the things that you need to do to try and keep yourself healthy. Okay, so human beings have this awesome ability to problem solve. Our minds are basically problem-solving machines. And we are super awesome at problem solving the external environment. So like the material world, right? Which is why we're standing here in a building with electricity and running water, right? So we are super awesome at controlling the external environment. And that problem-solving brain is really awesome if you are trying to fix something that is fixable, right? So if you need a shelter and your mind says to you, you need a shelter, and then it doesn't let up. It's like, you don't have a shelter. Where's your shelter? What are you going to do? Do other people have shelters? You better find a shelter. And if you just think more about making a shelter, eventually you'll make a shelter, right? The more you think about making a shelter, the better you are at fixing that problem. And then once you have a shelter, the problem is fixed. Right? And then your mind will do things like, well, do you have water? Where's the water? Do you have what? Do you have food? Where's the food? Right? And it goes on these series of problem-solving tasks on things that are fixable. Right? Once you find food, you fix that problem. Once you find water, you fix that water. And this is part of an ancient part of our brain developed in caveman times, which is still part of us today, right? So the way evolution works is that it doesn't replace old systems with new systems, it just builds on top of what's already there. So we still have that ancient kind of caveman brain in us, thinking about problem solving the external environment. And then the difficulty shows up is that then our minds notice things about us, and they try to problem solve that. You're in pain. Why are you in pain? What's the matter? Why did you get the pain? Where is it from? What do you need to do? What do you need to do to get rid of this pain? We better get rid of this pain. This is a problem, right? And it tries to fix things in us. The problem being that the things in us are not fixable. They are not things that we can make go away. So we can't make negative feelings go away. We can't make pain go away, right? We could maybe reduce them to some extent, right? But feeling sad, feeling angry, feeling anxious, feeling pain, those are all part of being a human being, right? Do you know anybody who never experiences anxiety or who never experiences pain, right? There is actually a condition where you don't have pain receptors in your body and they actually do not experience any pain at all. They are total disasters, right? They run on broken legs, they burn their hands without realizing it, they scratch out their corneas, they bleed to death without realizing it. They have incredibly shortened lives. It is very difficult to keep them alive. They'll like stand in the same position for too long or sit in the same position for too long and wear out their joints. And so not having pain is actually an incredibly problematic thing, meaning that all of these, anxiety, sadness, anger, pain, those are all part of being a human, right? There's no way to get rid of them. But our minds don't know that, and they go into this problem-solving mode. Why do you feel bad? What's the matter with you? Do other people feel this way? What's the matter with you? Maybe you should do something. Was it because of this? Was it because of that? And we go into this problem-solving mode. Right? Now, some amount of problem solving is absolutely appropriate, right? And if you can do things that help reduce your pain or make you feel better, then for sure you should go for that. But our minds won't stop at that. They will constantly try to get us to fix this problem that is unfixable. And sometimes that effort of trying to solve an unfixable problem is actually what gets us into trouble, right? So trying to not feel anxious, right? So people they'll avoid all kinds of things to not feel anxious. And that works temporarily. They, in the short run, they don't feel anxious, but in the long run, their lives get smaller and smaller and smaller as they have to avoid more and more things, right? Now, this is a totally well-functioning mind. If your mind is on you about trying to problem solve your pain or problem solve your illness or problem solve your bad feelings, that is exactly what minds are intended to do. Right? It just doesn't know that the things that you're currently experiencing aren't fixable. They are not things that you can make go away. Okay, so sometimes we get into trouble trying to manage things that aren't fixable, right? So for chronic pain, for example, things that we try to do to manage it, right? If you lay down and rest, your pain will feel better in the short run, right? It's just that in the long run, it doesn't help you. Okay, now, again, this ancient part of our brain from caveman times, our life expectancy was about 30. So really, we didn't have to worry about chronic anything, right? I mean, if you were dead by the time you were 30, we were always dealing with acute injury, acute illness, right? Short term, trying to survive for the moment. So if you have a broken leg, right, what's a really awesome thing to do if you have a broken leg? To rest, right? When we put a cast on it, we're not doing anything. We're just keeping it immobile so that it will heal itself. Resting is a super awesome thing to do if you have an acute injury or an acute illness. It's just that in a chronic condition, it doesn't work. In the short run, it works, but in the long run, you end up with more pain, right? But the fact that your mind tells you, you better rest, you're in pain, right? That's exactly what that mind is meant to do. Okay, so again, there's actually the things that we control the most, the things that are the most changeable or fixable, we have the most control over are actually our behavior, right? So that's things that people can see you do, right? We have actually a lot less control over our thoughts and feelings, right? So although we have the expression, don't worry, be happy, I don't know anyone in the history of the world who's ever stopped worrying when someone said, don't worry about that, right? Don't worry about it, right? So we have less control over other people's behavior, right? I do some couples therapy in my private practice, and you know, they come in, if he would just stop, if she would just be different, right? But we actually don't have that much control over other people's behavior. Again, we might be able to influence those things, but we don't have total control. Okay, and then again, other people's thoughts and feelings. Okay, so when we're trying to think about things that we can do, things we have control over, your behavior is the part that you have the most control over. Right, so behavior is whether you go for a walk or not. Somebody can see you do that. They could check off that that happened. Whether you enjoyed it or not, you don't have that much control over, right? Whether you wanted to go for a walk, again, you don't have that much control over that. But the actual behavior of putting one foot in front of the other, you have a lot more control over that. Right, this ancient brain of ours is actually completely designed to make us conserve energy. So back in caveman times, right, when we were getting the amount of exercise that triathletes get nowadays. So we were all getting the amount of exercise that triathletes currently get just to survive. So if you didn't have to move, you didn't move, right? You would conserve that energy because you were expending a lot of energy. And so cave people who were like, oh, I think I'll just go running for an hour for no good reason. Not smart, right? Because then they go out later on, they've run around for an hour for no good reason, and a lion comes out, starts chasing them and the other guy who just rested for the hour, right? Who gets eaten? Because they're both fit, they're like triathletes, right? But the guy who ran around for no good reason, he's the guy who gets eaten, not our ancestors, right? The people who are our ancestors rested whenever they rested, they took the path of least resistance. So if your mind tells you, if you're like, oh, I should go to the gym, I should go exercise, and it goes, maybe later. Why don't you do it tomorrow, right? Oh, you're too tired. It's exactly what minds are supposed to do. They're trying to help you conserve energy. It's just not that well suited to our modern environment, right? Okay, so when we talk about coping with chronic disease, there's two main forms of coping. The first one is problem-focused coping, and that is when you have a solvable problem, right? So these are problems that can be fixed, that you can make them go away. So a classic example is a deadline. You have to hand in a paper, or you have to send in a report, right? That is a fixable problem. If you work harder at it, you'll get that report in, and then the problem goes away. If you're in real life, then some other report will be due, and you'll do it all over again, but it's a fixable problem, right? You can make that source of stress go away. The other kind of coping is emotion-focused coping, which is when the problem can't be fixed, when you can't make it go away. And instead, we need to deal with the feelings that arise from that stressor, because there's no getting rid of the stressor, right? So which category do you think coping with chronic disease fits into? Fixable problem or not fixable problem? Not fixable problem. Right? And so most of us are trained in problem-focused coping. And if you are a high-functioning, person, you've been using problem-focused coping to get through most of your life probably pretty well. And then suddenly we get this chronic condition that we can't control, we can't fix, we can't make go away. And most of us have not had any experience with emotion-focused coping, of trying to manage the emotions that come out of a not fixable problem. So we get caught up in problem-solving something that can't be solved. Okay, so one of the forms of emotion-focused coping is what I call refueling activities. So some people might talk to you about relaxation exercises or things like that. I talk about refueling activities, which means that you feel more energetic at the end of that activity than when you started, right? So some people say, oh, I relax by watching TV. And at the end of watching TV, do you feel more energetic or less energetic, right? Now, sometimes you're watching a super awesome movie or something and you do feel, myself, I'm a total fan of like Avenger movies, so I leave an Avenger movie and I'm super excited about it. And then I totally forget about it, which is what I like about those movies, right? So to look for activities in your life that help refuel you, because your chronic condition is only taking from you, right? It's only wearing you out. And so to find ways to refuel yourself, to replenish your energy. Okay, so this might be all kinds of different things for different people. And part of the job is to try out different things and to see whether that makes you feel more energetic or less energetic by the time you're done. Okay, and then your job is to engage in those refueling activities so that you have enough energy to keep managing your chronic condition. Okay, so pacing is probably something that you've heard about. Everybody heard about pacing? Anyone told you should be pacing yourself? Okay, so what happens often is that we decide what to do based on how we feel. Right? So you wake up in the morning like, is this going to be a good day or a bad day? How do I feel? How much pain am I in? What am I going to be able to get done? And then it's a good day. So what do? Well, you do everything. You do as much as you possibly can, because who knows when you're going to get another good day, right? You better like do everything, right? Has that ever happened to anybody? Right. And the difficulty then is we overdo it, right? We go too far, and so then we end up having a bad day. We end up, we pay for it, right? We pay for it for a couple days afterwards where you can't do anything at all. And so, but then you start to feel better. Oh, it's a good day. Well, I better do everything possible because I just had 3 bad days and I couldn't do anything, so I better get everything done, right? And this is the challenge in pacing. The challenge in pacing, right, what you do when you're pacing is that you keep the same amount of activity and regardless of whether it's a good day or a bad day. So you pick the amount of activity that you can do on a bad day, and you stick with that amount of activity regardless of whether it's a good day or a bad day, right? And that makes you in charge of your day rather than your illness being in charge of your day, right? In this version, we have to check in. How do I feel? How much pain am I in? What can I get done today, right? Your illness is in charge of what you get to do that day. If you just do the same amount of activity, then you are in charge. You've picked the activity, and you do that whether it's a good day or a bad day. Now, the hardest part about pacing is holding back on a good day, right? That's the hardest part. It's not pushing yourself on a bad day. It's holding back on a good day, right? Because you're like, who knows when I'm going to have another good day? I better get it all done. That is the hardest part about pacing, is holding back on a good day. And when we do that effectively, right, you feel more in charge of your life because it feels less like your illness is controlling you. Okay, so you'll get lots of recommendations, right? I've already given you a ton. Find some refueling activities, engage in pacing, right? And I would bet that you've had lots of awesome recommendations from all kinds of people in your healthcare life, right? But stuff's going to get in the way of actually doing it, right? I would guess that almost all of us know exercise is good for us, right? And I can guarantee that most of us in this room, including the healthcare providers, may not get the recommended, right, 150 minutes every, right? I know in my workplace, I sit for way longer than 20 minutes. And I never once think about my posture until it hurts, and then I have to do something about it, right? Okay, so stuff gets in the way of following these recommendations. So we're going to talk a little bit about this, which is not just what you should do, but how do you actually do it? Okay, so what I would invite you to do is to imagine that you're a bus driver, okay? And on your bus are all kinds of passengers. And some of them are friendly and nice, but some of them are kind of bossy and annoying, and they like to tell you what to do, okay? And I'd like you to imagine that these passengers on your bus are your thoughts and feelings and sensations. So there's like an anxious passenger who's like, oh my gosh, don't go there. That could be a terrible place to go, right? There's like an angry passenger who's like, I can't believe he cut you off. You better go like tell him off, right? There's a pain passenger who's like, ooh, that hurts. You better not do that. You better rest. You better like wait. Don't do that. Okay? And everyone kind of, you know, get on board with that idea of having your thoughts and your feelings and sensations being the passengers on your bus. Okay, so sometimes the passengers seem to sort of take over our bus and take us places we didn't mean to go, right? So I'm like, get up in the morning, I'm like, oh, I'm gonna go to the gym. I'm gonna like go exercise, right? And I have a passenger who's like, you don't have time for that, right? I'm like, oh yeah, I don't have time for that. I gotta go give that talk. I have to get ready for that thing. I haven't like sent those emails, right? And all of a sudden I find myself not at the gym, right? So the passengers have sort of taken over my bus, taken me places I didn't mean to go. So given that the passengers sometimes are getting in our way of doing the stuff we want to do, what are some of the ways that we could try to deal with the passengers on the bus? This is an audience participation moment. Kick them off, of course. Wouldn't that make the most amount of sense? I mean, wouldn't I be a healthier person if I never had the thought, you don't have time for that? Wouldn't I go to the gym a lot more often? Right? I mean, if you weren't in pain, wouldn't you do a lot more things? Wouldn't that be awesome? Of course, right. Okay, so has anybody found a way to permanently not be anxious, not be in pain, or maybe not think? Anybody? No. No, probably not. Because if you did, I could probably diagnose you with something else, right? Right, which is the problem. This is what we do, right? When I'm not in pain, then I'll start exercising. When I'm not anxious, then I'll start socializing. We try to wait until the passengers are not there before we proceed, right? So the passengers sort of take over and take us where we didn't mean to go. Now, sometimes we take little detours, right? So like when I go to the land of like wine and chocolate, I don't hear them yelling at me quite as much, right? Then I wake up the next morning and bam, there they are again, right? Reminding me how I don't have time to do anything because I just wasted all last night drinking and eating. Okay, so we take little detours all the time to not feel them, but they're always kind of short term. Right? So given that it doesn't work to kick them off the bus, what are some other options? What else could we do to help manage the passengers? Learn to say no. Yeah, so, you know, we could like, sometimes we get in like a little debate, right? Have you ever had like a little debate in your head where you're like, ooh, chocolate cake, I really want some. No, no, you're trying to eat healthy. Yeah, but just this once. No, you're supposed to be on, you know, eating healthy. Yeah, but, you know, once it's gone, then you might as well just get it over with, right? Anybody ever had that kind of debate in your head? Yeah, I never seem to win those debates because those passengers, they're like way cleverer than me. Plus, they're offering chocolate cake and I'm offering broccoli, right? So they got a better offer than I do. They're offering staying on the couch and I'm offering going for a run, right? So yeah, not to mention the fact that when we're debating the passengers, we're also kind of still not paying attention to where we're going, right? Because we're busy kind of debating with them about what to do. Okay, how about if we try to ignore them, right? I'm not going to feel that, I'm not going to eat that, I'm not going to think about that, I'm not going to do that, right? So if you could imagine a passenger on the bus who's like, bus driver, I want to get off the bus. And the bus driver completely ignores him, does not acknowledge him at all. What does the passenger do? He gets louder, right? Like runs up to the front of the bus, I gotta get off the bus, right? So when we try to not think about things, to not feel that way, yeah, it actually gets worse, right? So given that all of those might not work, let's imagine now that you're the bus driver again, you're like a real bus driver driving around HRM, and a passenger gets on your bus and says, I'd like you to drop me off in front of my house. So just take your second left and your first right, and it's the house on the blue door, with the blue door. So if you were the bus driver driving around HRM and a passenger said that to you, what would you do or say?
It's not on the road.
Yeah, right? You'd basically say, like, you probably know to acknowledge them or they'd start screaming at you, right? But you would say, you know, sorry, but that's not on the route, right? And this is the relationship we're trying to cultivate with our own thoughts and feelings and sensations, which is that we can acknowledge what they say, but we don't get diverted from our route, that we stick to our route. Okay, so if that was the goal, then there's kind of two main skills you need. One, you need to know what your route is, where you're going, and you need to know how to deal with the passengers so you can stick to your route more often. Okay, so our route, one way that we can understand our route is what we call values. And this is about who you really want to be in life, what really matters to you, what's really important to you. These are the kinds of qualities that if you thought about, you know, being at the end of your life, how you'd want people to remember you. And again, not your current trajectory, but if everything could work out the way you want it to, what would really matter to you, the kind of person you'd want to be, how you'd want to be remembered. Okay, it's also the kinds of questions that if somehow your symptoms of your chronic condition weren't impacting you as much, what kinds of things would you do more of or less of, right? And why are those important to you, right? So people will say things like, I'd socialize more, I'd travel more, right? This is the kinds of things people say that they would do more. And what's important to you about that, right? What's important to you about socializing? What's important to you about travel? How is that an important quality about how you want to show up in life? Okay, so values are about the root, about what's important to us. And the thing about values is they're a bit like a direction. Okay, so our culture is very obsessed with goals, right? And goals are things that happen or don't happen. But values are more like the direction that you're headed. Okay, so for example, you might have the goal to get a university education, right? But there may be values that underlie that, like intellectual curiosity or self-growth, right? Things that are important to you about achieving that goal. And so whereas, you know, if it was important to me to head west, for example, there's a couple things about that. One, every step I take west counts towards heading west, right? That is me heading west. So it's not just the big events like getting a university degree that count, but all the little steps, because that's still me heading west. The other part is that I never actually get west, right? So I can't, you know, if being like a kind and loving person was important to me, I can't say, well, you know what, in 1989, I was super nice to my sister, so I'm good, right? If that's an important value to me, I have to keep showing up in that way. And then let's say, for some reason, you can't get your university degree. There may still be other ways for you to express that value. There may still be other ways to have intellectual curiosity or to express personal growth, even if that goal may not be possible anymore, right? So it helps keep us motivated on things, especially things that are difficult, right? So I would argue that pretty much if you're going to exercise at all, it's going to suck, right? So I don't actually try to get people to find something that they enjoy. I try to get people to be willing to be uncomfortable in the service of something that matters to you. If you are exercising more and you are somehow more flexible, why is that important to you? What are you going to do with that extra flexibility? What are you going to do with that extra range of motion? Right? If you're just going to sit on the couch, then, you know, don't bother doing the exercise. Just sit on the couch, right? What are you going to do with that extra flexibility and energy and activity that really matters to you? That's going to make it worth it for you to do this crappy thing we call exercise. Now, if some people like exercise, that's fine. If you do and you have something you enjoy, fantastic. But if your passengers are still like, how about tomorrow? Why bother, right? Again, that is a normal, well-functioning mind that's trying to help you conserve energy. So we spend a lot of time trying to convince people that all the healthy things we're asking them to do won't be that bad, when really they often suck. And what we really should be doing is asking them what's going to make it worth it for you to do this difficult thing, right? We do difficult things all the time. All of you people got up this morning, you got dressed, you came here instead of staying in your nice, warm, cozy beds, right? We do difficult things all the time for the things that matter to us. Exercise might just be one more difficult thing you do in the service of things that really matter to you in order to have the life that matters to you, right? So you can hate every minute of it. As long as you're still doing it, it still counts, right? And the behavior part is the part you control. So I was saying earlier I'm training for a half marathon, and I hate every minute of it, right? I do not enjoy running. But I think I'm going to enjoy saying that I accomplished a half marathon. That I think might be cool, right? But the actual running part totally sucks. Okay, so let's do this little activity just to examine how do the passengers take you off your route. So if you could imagine setting yourself a self-care goal, right? Or maybe one of the recommendations you've heard today. Like when you get home, you're going to start pacing, or you're going to start monitoring your posture, or you're going to start with your, 10 minutes of exercise, that kind of thing. So one of the recommendations that you've heard were some self-care activity to think about setting yourself a goal. Okay, now it should be something that you're not currently doing, but something that you could do. Okay, so a little bit outside your comfort zone or what you're currently doing, but not impossible. Okay, can everybody kind of pick a goal that they can use for that activity? Okay, so now just pause and notice. When you think about doing that goal, what kind of thoughts show up? What kind of feelings show up? What do the passengers say to you, right? Oh, you tried that before, it's not going to work. Why bother? You're not going to stick to it. That's going to cause too much pain. You better not. Right? What do they say to you as you think about trying to do that goal? Right? Do you have one of, like my passengers, you don't have time for that? Got one of those? Okay, can everyone kind of notice the thoughts and feelings that show up?
But I like beer.
Yeah, exactly. Right? No one ever binge eats on broccoli. Okay, so did any of your thoughts fit into any of these categories? Obstacles, judgments, comparisons, predictions. Right? Basically reasons why not. Why this is not a good idea and it's not going to work out. Did any of your thoughts fit into that? Did most of your thoughts fit into that? Right. Well, congratulations, you are well-functioning humans. Right? Again, this is our ancient mind protecting us, right? Not wanting us to do new things. When you were a cave person, doing new things was probably a pretty dangerous thing, right? A cave person who had no inhibition, who just like launched into new things all the time, probably didn't survive too long, right? Ooh, water, let's go swimming. Ooh, mushrooms, let's eat that, right? Again, not our ancestor. So people who were hesitant and didn't start new things, who stayed safe in the cave, are probably the people who survived. So our brains work on the principle of the devil you do know is better than the devil you don't know, right? So let's just stick with what we already know, even if that's not necessarily working for you. Okay, so the little cartoon says, something's just not right. Our air is clean, our water is pure, we get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30, right? This is the world that that ancient brain was designed for, right? It was evolved for this environment where you didn't have to worry about chronic anything. So we also have developed, right, we've also evolved a frontal lobe, which allows us to delay gratification and make plans and make decisions. But that part is an effortful, conscious, deliberate choice, right? It requires effort to activate. This ancient part of our brain just shows up, right? Feelings just show up. Thoughts just show up. We don't have to make them show up. It's like breathing. That same part of our brain controls breathing. We don't have to think about breathing, right? We don't have to be like, breathe in, breathe out, breathe in, breathe out, right? But you can get a form of brain damage which actually impacts that part of the brain, and you have to consciously think about breathing or you suffocate, right? At night you have to be in a machine that breathes for you. Okay, so that part of our brain is automatic. It just does stuff that shows up. So those passengers that show up, the stuff that just automatically shows up, right? That's this part of the brain at work, which works awesome, right? If you're a caveman and you're only going to live till 30, totally focused on right now, right? Conserve energy. It just doesn't necessarily work for our modern environment. Okay, so basically, sometimes your passengers are going to give you bad advice, right? These are like tricks of the mind, right? They're going to give you advice that you've probably tried and in the long run doesn't help make a life that matters to you, right? So when you're like, oh, I should exercise, right? And your passengers are like, oh, that's going to make you be in more pain. I don't know if that's a good idea. Maybe you should just rest, just let it be, right? You're not having a flare-up. What if you get a flare-up? Just, don't bother, right? And again, if that is helping you build a life that matters to you, to follow what the passengers say, then go for it, right? There's lots of times we do follow what the passengers say. This morning I had the thought, get up, get out of bed, go give a talk, right? So it's super awesome that I paid attention to those passengers and did exactly what they said. So this isn't to say that you shouldn't listen to your passengers, but sometimes they're going to give you bad advice, right? They're not out to get you. They're just giving you advice that would work super awesome if you were a caveman and just not so much nowadays, right? So my mind tells me all the time to eat ice cream. You love ice cream. It's your favorite food. Remember how good it tastes? Except it actually makes me sick. Right? So, but I fall for it still sometimes. And then when I'm eating it and I feel sick, I'm like, why did I do that? I know this isn't good for me, right? So we can't stop your mind from giving you the bad advice, but you can stop yourself from falling for it, right? So now when my mind's like, oh, you love ice cream, it's your favorite food. I'm like, I know this one. You got me before, but not this time. Thank you very much, but no thanks, right? Okay, so it's like those emails, when you get emails into your inbox that are like, oh, give us your bank information and we'll give you $1 million, right? We can't stop the messages from coming into your inbox, but you can stop yourself from clicking on the link, right? Your brain, as a well-functioning brain, is going to give you all kinds of advice that would be awesome for a caveman, but may not help you live a life that matters to you now. Okay, so we often try to not think about stuff, right? As soon as people start to try to eat healthy, they think about the things they're not going to do, right? We try to not be upset, try to not think about your pain, basically try to ignore the passengers. So let's do this little activity, if you are willing, to try very hard for the next 30 seconds to not think about pink elephants. So don't think about pink elephants, don't imagine pink elephants, no pink elephants. Okay, everybody ready for that? Okay. Go. Okay. What did you notice? Did anyone happen to think about pink elephants? Or did anyone have to work really hard to not think about pink elephants, like green monkeys or something like that, right? Yeah, and were pink elephants like a big topic of conversation, like on the Facebook group? Everyone's like, ooh, pink elephants. Like, we're all thinking about that a lot? Probably not, right? But the minute I tell you not to think about it, now you're thinking about it, right? And this is a well-established effect in psychology called the thought suppression effect. The more you try to not think about something, the more you think about it. So we generate pink elephants in our life all the time, right? By setting ourselves don't do goals instead of do instead goals, right? I'm not gonna eat chocolate anymore. What are you gonna do instead of eating chocolate? Okay, so if, you know, ignoring the passengers isn't gonna work, like what are our other options, right? They keep giving us this bad advice. So maybe we could just thank the passengers, which is that whatever they tell you, they honestly are doing that with your best interest at heart. They really think that you're in the jungle and you're about to do something life-threatening, and they're doing their darndest to try and protect you, to try and keep you safe. They just don't know that you are in this environment where you're actually trying to pace yourself instead of going exploring in the jungle. Okay, so with some genuine gratitude for their really hard work and efforts to try and take care of you, when they give you that advice, you could maybe just thank your passengers, right? Thanks very much, but no thanks, right? The bus driver doesn't get on the bus and is like, okay, so I'm gonna head down Barrington Street and then I'm gonna take a right on Spring Garden. Is everyone okay with that? No, he just follows his route, right? You don't have to have all the passengers agree with you in order to do something. Okay, so these are some additional resources if you're looking for some things that might help manage your chronic disease. These are some books that deal with ways to try to basically manage your passengers more effectively. I'm actually totally delighted to tell you that I'm writing a book that's going to be out that's all about the fact that healthy habits totally suck. And how are you going to make that willing for you to do it? The title is actually Healthy Habits Suck. Yep. Okay, so at the Behavior Change Institute, we do workshops for healthcare providers on chronic disease management. So we teach healthcare providers ways to help them better manage chronic disease, right? The healthcare system is really designed for acute injury and acute illness and not really for chronic disease management. So most healthcare providers are not really well trained in effective and scientifically based ways to manage chronic disease. We also do things on professional readiness, coping with chronic disease. We have a research project right now that's a 10-session telephone intervention for people with chronic condition who are in the workforce but are at risk of leaving the workforce. So to help them cope better with their chronic condition so they can stay engaged in the workforce. Okay, I thank you and all your passengers for being here.
Thank you very much, Dr. Lee-Baggley, for that incredibly engaging presentation. You certainly gave me some tools that I will be using in my own personal life. And last but certainly not least is our patient speaker of today, Chris. Chris is from Halifax. He works as an economist, has lived for many years with ankylosing spondylitis, and like Gloria and myself, he has spent more than a decade volunteering in a number of arthritis organizations. He is currently the patient co-chair of the Chronic Pain Network's Clinical Research Network. Welcome, Chris.
I'm going to stand behind the table because I have notes to remind myself of my history. The details are sketchy at this point. So thanks for inviting me here to speak today. I kind of saw myself in everything that everybody else talked about. I thought, I was feeling really confident. I thought, I might be the only one here that wouldn't have imposter syndrome because I actually have ankylosing spondylitis. But after Dr. Bakowsky's talk, I'm not so sure anymore. And I'm also worried that you're going to judge my posture because I can only relax 5%, not 10%. And that's because I have intrusive thoughts because my right leg is asleep and I can't stop thinking about it. So I'm getting anxious. But anyway, so I was asked to come and talk about my experience with ankylosing spondylitis, kind of how the disease progressed in me, how it showed up, and what I've done over the years to deal with it. Can I ask how many people here think or have been told that they have one of the diseases that we were talking about today? Yeah, so I'm 47 years old, and I have had ankylosing spondylitis, I think, for about 36 years. So it started showing up in me when I was 12 or 13 years old. And I'm going to tell you a little bit how it developed. It may be a little bit too much detail for you, but you may also see yourself in this story too. So almost exactly like Dr. Bakowsky said, when I was about 12 or 13, I noticed my Achilles tendon started to swell up and became really, really painful to walk on. And a few months after that, my left knee blew up. So I had Achilles swelling and pain in my left knee. And at that time, my parents took me to my family doctor, who diagnosed me with one of the most devastating diseases I've ever been told, which is growing pains. So essentially, you know, no background in rheumatology at that time, and not a lot of awareness about, I think, what these symptoms might have been showing. So I was given, told to take kind of over-the-counter pain medication, and it'll probably go away as I get a little bit older. But it did, and it got worse, and I was very active. I was playing hockey and tennis and doing dangerous things on bicycles, like, you know, any other kid that was raised in the 70s, before cell phones and video games. But things got worse over the next few months, so I was referred to a sports medicine doctor, because it must be an overactivity sort of injury type thing. So I was then diagnosed with Achilles tendonitis and Osgood-Schlatter's disease. I don't know if you've ever heard of that, and I don't even know if that exists anymore. But it's basically, you know, young people in a growing stage who are physically active, knee swells up. That's probably what it is. So again, more over-the-counter medications, and still didn't get any better, continued to get worse. So my orthopedic doctor decided to put me in leg casts. Yeah. So over the course of the next few months, I was in a series of ankle casts to try and calm the inflammation in my Achilles tendons, and then I was put in a full leg cast to help my knee. And as you can imagine, that was probably the worst thing that could have ever been done. So from that, the muscles in my legs atrophied. It took me a long time to get my balance back, and it was at a time when, the physio exercises that I was prescribed, I didn't really do because I was 14, 15 years old. So those kind of, I guess, not misdiagnosis, but underdiagnosis sort of led to a lot of problems that exacerbated over the years. So again, things continued to get worse. I still tried to remain as active as I could through my teenage years, but then I started to feel pain in my back, through my hip, which I later learned was my sacroiliac joint. So now, you know, if you were a rheumatologist at the time, you'd probably laugh that nobody could figure out what this was, but 2 inflamed Achilles tendons, an inflamed knee, and now an inflamed sacroiliac joint. So somebody finally clued in and referred me to rheumatology in my early 20s. So I went about 10 years without being diagnosed, which, as a lot of people probably know, it's common, even today, I think, and can cause a lot of problems. So once I finally saw rheumatology, and I had the HLA-B27 test done, and she looked at me and said, I think you have ankylosing spondylitis. So that was a terrifying thing to hear, for sure. So then I went on one of the NSAIDs that Dr. Bakowsky was talking about. It was called Voltaren, and I don't know if that's used anymore. It was sort of the standard of care at the time, yeah. At that time, too, I was invited to a sort of a seminar just like this, where I sat around. It was more of a roundtable discussion with people that had been diagnosed. And to be honest, it didn't make me feel any better. It actually made me feel worse. I heard of all the terrible things that can happen to you when you have ankylosing spondylitis. And people said things like, you know, they asked me, what are you studying in school? I said, finance. They said, okay, well, that's good. because you won't be able to do a physically demanding job. It's good that you can have a desk job. So I left that seminar feeling very depressed and kind of despondent, and thought, I don't want anything to do with support or information ever again in my life. So I spent the next probably 10 years sort of pretending that I didn't have ankylosing spondylitis, maybe thinking that maybe they got it wrong, you know, maybe it is activity related, sports related, and I'll just continue to keep doing the things that I'm doing and hopefully figure something out. I also started to explore some of the more alternative or natural, I guess you could say, complementary treatments, therapies, things like yoga, meditation, lots of crazy elimination diets, loads and loads of supplements. No green peppers. I can't even say the word. And you know, I'm not going to say that all of those rabbit holes that I went down were useless. I think I learned a lot of different things, and I do feel that some of those things do help me in my life. Did they end up curing my ankylosing spondylitis? No, they didn't. So that decade passed, and my disease stayed relatively stable, and it has throughout most of my life. But I realized it was destabilizing when I went on I used to lead these wilderness sailing expeditions with the Nova Scotia Sea School, which is a really cool organization. Yeah, you know it? Good. So I was on one of these trips, 7-day trip with a group of teenagers, and my left eye just started to blow up. And I thought I must have scratched it with something or a chemical got in. I had no idea what was going on, but I couldn't see, and it was the most painful thing I'd ever felt. So I went to the emergency room when I got back to shore, and then was eventually diagnosed with a uveitis or iritis. I still don't know what the difference between those two things is. So then I realized that that's when I first learned that ankylosing spondylitis and these kinds of arthritis can affect more than just your joints. And it was at a time when, I think it was right around the time when I became Dr. Bakowsky's patient. He started to talk to me about some of the biologic treatments that were relatively new at the time. And at that point, I think I was on Celebrex because Voltaren had sort of lost its effectiveness, and I think Celebrex was a safer drug at the time. So he started to talk to me about the biologic therapies. And like he said, I read all about them, and I was scared. They sounded terrible. The side effects, the potential risk, all that sort of thing. So it took me a full year, I think, to decide from the time that he first talked to me about it to the time that I actually started on the therapy. And through that year, I had a number of iritis, uveitis flares, and my physical disease was getting a lot worse. And he said something to me that he sort of talked about earlier today, which was that, not that he was trying to persuade me, he wasn't, but he said that there isn't a zero risk scenario in all of this. You know, there are risks associated with medications, and there's risks associated with not taking medications. And in fact, the risks associated with not taking medications are kind of known. Chronic inflammation and pain leads to all kinds of really bad things. So I started on the biologic, and I was one of those cases that within days I was almost symptom-free. That's not to say that I haven't had problems over the past 10 years, but you know, I've had a cycle of flares and nothing, I don't think, medication-related, but it hasn't fixed the problem 100%, but I would say that it's allowed me to remain active and have a level of pain. You know, I do have chronic pain. I feel pain every day, but it's manageable. And I've been able to maintain the level of activity that I have always been used to. So I play ice hockey a couple times a week. I go to the gym. I ride a bicycle, all this sort of thing. So right around that time, sorry, I forget my life, just a sec. And my password. So right around that time, I also was approached by somebody that I know who knew that I had ankylosing spondylitis. And that's kind of a whole other story, which is that nobody really knew that I had ankylosing spondylitis. It's something that I really kept to myself. It was very private. My friends and family knew. I should say a few of my friends and my close family knew, but it's not something that I ever shared with anybody. It's not something that I ever really talked about. And I think it's because I felt maybe embarrassed about it. I felt like I didn't want people to think of me differently than a normal person. I think it was also because I was diagnosed, it started to occur to me when I was a teenager, and other teenagers can be relentlessly cruel. So if I had a limp or if I, was in pain and I couldn't do things, I would just get made fun of. So it's something that I never really talked about. But around that time, coincidentally around the time that I started Humira, somebody approached me to join this patient sort of advisory panel with an organization called the Canadian Arthritis Network, which isn't around anymore, but I agreed to do it, and I was really not, I wasn't optimistic about it based on my previous experience with support groups, I guess. This wasn't a support group. This was a group of patients with arthritis who were working to increase the involvement of arthritis patients in research. So I went to my first meeting, and I was just shocked to be, in a room with people who were talking about the fact that they have arthritis. And they were sharing, what medications they're on and their coping strategies, and it was just, it blew me away. I suddenly felt like, wow, other people understand what this is about. So that led me to kind of get involved with different organizations, and it's been really good. It's just been really good to be around people who understand what I've gone through, more or less. It's important not to feel like you're alone, I think. You have your close family, but you can let other people into your circle, I think is what I've learned. So it's been it's been almost 4 decades, and I think I've learned about 5,000 things, but I decided to write down 5 things that I've learned. I'm going to read them to you. So the first thing that I've learned, I think, is that I need to be my own most vocal advocate in all of this. So as you may or may not have experienced, pain isn't always a visible thing. So people look at you and you look normal, but you're not. You feel like you're suffering. You feel like you're in a lot of pain. And if you just describe it even, it's difficult to do that. Well, I'm tired, this hurts, that hurts. It doesn't ever really sound like it adds up to much sometimes. That's one of the most challenging things for me, has been to communicate how I feel, like what this pain does to me. So it's been really important that I learn how to articulate that, and to push my healthcare providers to give me what I feel like I need. So to be my own advocate. Also, to never leave an appointment without saying what I feel like I need to say, or ask a question, no matter how small it may seem to you. It may not seem like a major, pain-related question, but sometimes the smallest things. I mean, there's research out right now that says that, yes, pain is arthritis patients, I'm not going to say #1 concern, but fatigue is right up there too. So sometimes we don't talk about the fatigue side of it with our rheumatologist. We just want our pain dealt with. But fatigue is something else that can really affect your life. So the second thing I would say is that I've learned to try not to suffer alone, and that's sort of what I talked about, is connecting with other people who have similar experience and going to things like this. And thank you for putting these things on. This is really great. The third thing is that I've learned to trust my gut myself, as well as my healthcare team. So they don't know everything about my disease, and I don't know everything about my disease, and Google doesn't know everything about my disease. It knows a lot, but so it's kind of mediating between those 3 things. You know, you have experts in your life that will tell you one thing, but it has to, like Dr. Bakowsky says, it has to work for you. It may be technically the best treatment that is out there, but if it doesn't work for you for some reason, you have to kind of accept that and communicate that to your healthcare team. The same goes with exercise. You know, the guidelines are very clear, but nobody follows the guidelines. So it's finding a way to be realistic about, I think, what happens if you do follow them and what happens if you don't follow them. The other thing is that I've learned that if I need treatment, so whatever that means, I try not to delay making that decision. So time is really of the essence. I wasted a lot of time, you know, thinking about whether or not I should take various types of treatment. But now, if I'm not feeling well, if I need something addressed, I need to get it addressed quickly, because those problems just stack one on top of the other, and then it's hard to get back to where you were, if you ever could. And the fifth thing is very practical for me, and that is, somebody said it, like, if you could just not ever stop moving, that would probably be the best thing, is to you know, to be as active as you possibly can. And you know, I would say the couch and Netflix can be your worst enemy. They're so attractive. You know, I think that we are all capable of doing even just a little bit more than we think we are, maybe even just a little bit more than we're advised to do by our healthcare team. So it's about pushing yourself a little bit further than you would normally go. And for people with arthritis, that can be as simple as if you need to use your arms to get up out of a chair. It becomes habitual, but some people need to do that. It's about, you know, is there something I can do that I can get to a place where I don't need to push myself up with my arms from the chair anymore? It can be as simple as that. Yeah. So that's actually the last thing I was going to say. I think it's that, you know, you have these healthcare professionals in your life, but ultimately the responsibility for yourself is your own. You may only spend 2 or 3 hours a year interacting with a healthcare professional, but you've got more than 8,000 hours a year where you're sort of in charge of your own well-being. So those are some of the things that I've learned. Thank you for inviting me here to speak, and thanks for coming today.
Thank you, Chris, for that really interesting talk. The patient voice is always an incredibly valuable one, and it's always very interesting to hear from a really engaged patient advocate. We're now going to begin the question and answer section of today's session. Could I ask our experts to come up front, please? Yes, please. Or maybe have you all just sit up here, maybe? Or just have a seat? Oh. Okay. I've collected a few questions from our audience here today, and I'm sure we have some online as well. I had one question that I'd like to start off with that coincides with one question asked by a member of our audience. And this is for Dr. Bakowsky. The CSA is creating awareness around the many comorbidities associated with spondyloarthritis. Can you talk a little bit about why we are more susceptible to stroke and heart disease than the general public, and what can we do to prevent this?
So, do I have a microphone, or?
Oh yeah, you took yours off?
We don't need it?
Go ahead. There we go.
So there are a couple reasons for this association between a greater risk of vascular disease and spondyloarthritis and psoriatic arthritis. Basically, kind of any inflammatory state, you know, isn't great for your arteries, and so, you know, there are similar studies in rheumatoid arthritis and lupus, and so there are now some studies that suggest the same is true for spondyloarthritis and psoriatic arthritis. The amount of risk may not be quite the same, but at least there's a potential signal there. Now, the increased risk is not huge, but if you take a common disease and you increase the risk even a small amount, it translates into, you know, a public health issue. And also, you know, individually, if you're affected, then your risk is 100%. So it's probably to some degree related to the disease and the inflammation itself. In psoriatic arthritis, there is an association between obesity and in high BMI and psoriasis and psoriatic arthritis. So it is possible that some of the risk factors for vascular disease are found in greater abundance in people with psoriatic arthritis. And then finally, there are the potential for treatments to affect risk, right? So anti-inflammatories can potentially raise blood pressure a little bit. Again, you know, a point or two of systolic blood pressure, you know, it's not really a huge deal in an individual, but if you take the number of people on the drugs, then even a small increased risk in systolic blood pressure may have implications. So those would be, I guess, another potential reason is if you're affected by a condition that interferes with your ability to be active and engage in healthier behavior. So for all those reasons, people surmise that could have an effect on vascular risk.
It's a similar question online that's a little bit different. It says, what are the signs for the patient that the heart has been affected by spondylitis? Would that be high blood pressure? Or?
So one of the non-sort of musculoskeletal things that can happen in spondyloarthritis is you can get aortic valve disease. So your aortic valve can be leaky. It's pretty rare. So, you know, I think your risk is very, very low. People should listen to your heart every now and then, and if people developed shortness of breath, that's one of the things to consider. Otherwise, you know, it doesn't tend to affect the heart itself, the heart muscle. If people are getting, you know, coronary artery disease, which is very, very common in the regular population, the things to look out for would be exertional symptoms, exertional shortness of breath, exertional chest tightness. Those would be the symptoms to be on the lookout for, and that's true whether you have spondyloarthritis or not. So.
Perfect, thank you. Okay, thank you. Could we pass the microphone to Susan, please? I think this is a good question. What is your opinion on a waterbed for people with spondyloarthritis?
You said, like, continually moving is a good thing.
Yeah, you still have to be able to get in. You have to be able to get in and out of it, though. So as far as beds and mattresses, you can't, you know, you want to be in a relatively neutral position all night. So you want enough support that your body's not sagging in the night. So the way people are built, you know, if you're heavier through the hips, you're going to sag more in that area on the bed. So if, you know, I usually say to people, if you're not waking up in the middle of the night with pain, your bed's probably not a big issue. For the most part, I do recommend a more firm surface, you know, good coils for the mattress, but the softness on top so that you can have softness to fill in the contours. Now, that said, if you sleep in a waterbed and you feel, like I said, if you feel good in the morning and you're not having too many issues, I wouldn't worry about it. So, but mattresses themselves, you know, ideally firmness so you don't sag, softness on top, and, you know, usually replacing a mattress every 10 to 15 years is recommended. So,
I have something quickly to add about that. Was that your question?
Well, we just got a bed.
Oh, did you?
Now I'm completely second guessing it.
No, it was the 70s, so I had a waterbed. I didn't even know they made waterbeds anymore, but I had to end up sleeping on like sort of a mattress on the floor because I couldn't. The waterbed was just killer for me. Yeah.
Okay, and Dr. Lee-Baggley, what is the best way to help change your perception of pain?
Okay, so So one thing about pain is that it's sort of like a pipeline that goes from your body up to your brain. And the signal for pain has to make it kind of through that tube and up to your brain before you will experience pain. But it's a limited amount. There's only so much information that your brain can take in at one time. And so if you are doing other things and have other sensations going on or thoughts going on, it'll actually fill up that pipe. And so not as many pain receptors make it to your brain, and you actually will experience less pain. So there's like a finite amount of information your brain can process at any time, which is why, if you've ever stubbed your toe and you rub your toe, the rubbing actually is a different receptor than the pain receptor, and it actually moves faster. And so by rubbing your toe, you're giving different sensations that fill up that tube, and you don't experience pain as much. That's why rubbing your toe if you stub it helps. So, one of the things about managing pain is that if you have nothing else to think about but your pain, you're going to be experiencing a lot of pain, right? And again, your brain's going to want to problem solve pain because it thinks it's an acute injury that you need to solve. So doing other things to fill up that tube so you have other things to think about is one of the ways to manage pain because not as much is going to get to your brain to experience pain. I don't know if that answers the question, but.
We have quite a few questions on the biologics. How many of our life activities do we get back if we start on a biologic, and how much do they cost?
So how much life activities are you going to get back? I think, I would certainly make no promises to somebody. I think it's a situation where you have to try it and see. And I will say that if I had to, we use biologics in other diseases like rheumatoid arthritis. And if I had to choose that I only had one disease to treat, I think I would choose spondyloarthritis and psoriatic arthritis because they're often quite effective, right? But they don't work in everybody, and obviously, if you are in the later stages of disease and your spine is fused already, it's not going to provide mobility where the spine is completely rigid because of fusion. There's always mileage may vary kind of comments and whatnot. And so what I try to emphasize for people is that the decision to start a medication is not the same decision as whether to keep it going. And so, you have to try it and see. And if it's not a giant bang for your buck, then maybe the decision should be not to continue it. So it can, I have patients who it's been a life-altering therapy for them and given them their life back, and I've had patients who, have had no benefit. So you can't really make any promises. How expensive they are, when they came out, they were sort of in the range of close to, $20,000 per year. And for the first, few years, I had to kind of sit down when I told people that because I couldn't really believe it myself that a medication could be that expensive. I've sort of become extinct to that. There's been an extinction effect, and now I don't have to sit down anymore. And so fortunately there are is insurance and whatnot that helps mitigate. Yeah, but this is costing somebody is paying for it, and I don't really know. Are we on the path to the end of the world? Because this is the way medicine is going. It's much more individualized. It's much more expensive, and so fortunately the cost has come down with the introduction of biosimilars. They're about 30% less, and then that drives down the price for the sort of originator drugs because they try to match the cost. So with time, I hope they become more affordable. But what I think, see, I wear many hats. One hat is trying to look after the good of the whole system. But when a patient is in front of me, my focus is on that patient, and so to some degree, like as we've been told, you have to be your own advocate, and you know, I think to some degree you just have to think about, you know, your own health and worry and not worry so much about the system as a whole.
Are there any statistics on biologics becoming ineffective?
So they do become less effective sometimes. So we divide, if it's not working, we divide it into primary failure, which it never worked at the beginning, versus secondary failure. So primary failure, you know, one of the things we do is we reevaluate the diagnosis. Are we sure that the diagnosis is right? Because the medications, you know, frequently do work to the point where if it never worked, it's a bit of a red flag. And so one possibility is, you know, back pain is extremely common in the regular population, and if you have spondyloarthritis, you could have a bulging disc pressing on a nerve, or you could have another reason for back pain too. But if it's a primary failure, you know, one of the things we would consider doing is just switching to a different class of drug, because maybe that telephone line that we're cutting, maybe that's not important for that person, right? So secondary failures, we think is probably something else, and sometimes people wonder about, because these drugs are this giant sort of protein molecule, that you could potentially develop, you know, antibodies against that drug, because it's you know, it is somewhat foreign to you, and so maybe people are generating antibodies, and then the drug levels are dropping, and maybe that's the reason why there's a loss of effect over time. So, but we probably don't really completely understand it. It's probably more than that. So sometimes switching around after loss of efficacy is a reasonable thing to do, and sometimes the disease just progresses too, and it does get worse. So there are multiple reasons.
And a question for either you or Susan. How do you know when you're in a flare-up?
Well, more pain would be one. Certainly, the morning stiffness is another cue that you can use. Is that in the morning stiffness? Is that stiffness in the morning that you feel when you first get up until you get down to normal level of stiffness? So if that's lasting for more than 2 hours, that's a cue. Fatigue, increased fatigue, obviously obvious joint swelling, that type of thing. Anything else?
There's one here. If you have inflammation to the particular joint, is it okay to exercise? Will that cause more damage?
Yeah, so you don't want to stress the joint if you're in flare. You don't want to add more impact. So if it's flared, you stick to your more gentle, your range of motion types of things, exercising in water where the joint is unloaded. Those types of things are definitely much better.
Okay, perfect, thank you.
This is a very interesting question. This would be for the whole panel. Do you ever see us moving to a multidisciplinary team, like a treatment plan, where your physician, physiotherapist, rheumatologist, psychologist, naturopath, etc., are all in the same room for appointments and have a comprehensive treatment plan?
That would be good.
In the ideal world, I would love that. That would be awesome. In the financial world of the healthcare system at the moment, not in the near future.
Not Nova Scotia.
Not Nova Scotia. Anybody else have any comment on that one?
I almost tried to do that once. I did. I tried to get a couple of my other healthcare practitioners to come with me to see Dr. Bakowsky, but couldn't do it.
I had one about here, about are night sweats a symptom of ankylosing spondylitis?
I would be very hesitant to say it's related. I mean, there are lots of other causes of night sweats, but I wouldn't blame the disease. Yeah. Anywhere from, you know, a who cares problem to a serious problem. So it's yeah.
How do you cope when you don't have access to your rheumatologist for a significant period of time? Perhaps that person has been ill, and it's been say, a year and a half since you've seen someone, how do you cope? Who do you go to?
That's actually never happened to me, but I'm lucky in that way. I mean, I see as many different types of healthcare practitioners as I can, or that I feel is helpful to me. So I manage between appointments or during flares with visits to, I see an osteopath, I see a chiropractor, I see a physiotherapist who's very familiar with my particular condition. So I'm kind of constantly managing my disease, but I've been lucky in that I can get in to see Dr. Bakowsky at fairly short notice if I need to.
You have to be the CEO of your own health. And,
Yeah.
And, you know, massage therapy also. If
Exactly,
you're
yeah.
having a bad time.
Yeah.
This is a very common question. Is there a specific diet plan recommended for spondyloarthritis? We're all looking for
Many.
the miracle diet.
Then fix it brain, looking for the
Yeah.
diet that's going to fix
Yes.
your condition.
I think Dr. Bakowsky did give some hints on
Yes.
diet there.
Yeah.
Yeah, so most medical evidence, I mean, it is driven by the pharmaceutical industry. It's very expensive to do clinical trials, and so there is often not as much resources put into some of these other types of interventions, right? So oftentimes, there's just an absence of evidence. It's not that the evidence is negative, it's just that there isn't much evidence there. And if the issue is, eating more carrots, right? I want to eat more carrots. The burden of proof, I don't think needs to be as high as if you have a drug that's potentially toxic, right? It's just eating carrots. Like my mom said I should eat more carrots. She was right about, almost everything. So and a lot of, what we do, you go to the doctor says do this. There's a loss of kind of control that we've heard about, and people really want to have something that they can do themselves that is relatively straightforward. So I think if you're following any kind of diet and you feel better for it, as long as it's not nutritionally deficient, then more power to you, right? But it's a bit of a different question than, what do you tell everybody? Because if some person, decided they're going to eat more, fava beans, you can, if you eat too much fava, you can get favism, which is kind of a disease. So maybe that's a poor choice. But if you're doing that and it's making you feel better, I can't necessarily recommend it to the next person. What I can recommend is, eating more vegetables, eating more fruit, eating things in the way nature designed them, right? There's a lot of nature designed an almond. It's got fat in it. It's got it's very nutritionally sound. You absorb all that goodness in it because it's a nut, and it's through evolution, it's designed a packet that makes animals want to eat it, right? So I think emphasis on fruits and vegetables, and emphasis on making it yourself, because then there's not that guar gum and lecithin. Well, lecithin is probably fine, but there's not red dye number 6, and I don't think there are really shortcuts in many things, and so that's what I emphasize. It's maybe not the most popular thing because it's not so easy. Be easier just to avoid things that are red, for example. But anyways.
What about eliminating starches? Like, have you tried that?
Oh yeah, everything.
Okay.
I have to.
You pretty much can't eat anything.
Yeah.
So we tried diet with that.
I gave it up after a while, but yeah, I did the no starch.
Somebody had written a book that I had gotten, and it was
Yeah.
It's hard to
how to
maintain.
cure your ankles as well.
Mm-hmm.
The leaky
Yeah.
gut syndrome. And,
Yeah, yeah.
Okay.
I do
You
find
do
sugar.
dietary changes, but yes, you find sugar.
I find high sugar if I eat a lot of sugar, like if I go and eat the ice cream or whatever there, and I consistently have bad diet over a few days, unhealthy diet, then I'm flaring.
So, I mean, I'm actually, it's a bit peculiar how you end up where you are, because I'm this person. I always saw myself as a bit of a rebel or anti-establishment, and here I am. I'm the picture of the establishment, and I'm also anti-drug, right? I think, you know, the right amount of drugs is the least amount of drugs that you need, and then here I am, you know. So I'm not sure how I got here, but I can assure you that if there was something, you know, natural that I could tell people to take, like I would tell people to take that, because that's part of my belief system, and so, you know, I'm not this horrible person trying to keep the truth from the general population, and you know, I would love to just say goodbye to medications, but you know,
I should clarify that we have on medications as well.
I would just say that if there was a simple fix, like just don't eat that, then this would not be a chronic condition. Everyone would be recommended to do that, and no one would have that condition. It's probably really messy, really complicated, really uncertain what to do. And so anything that tells you just do this and you'll be better is probably not a solution, right? It's a complicated process. Even the recommendation, like do exercise, like exercise, you know, is one of the things, like do exercise. But that's actually a complicated thing to do, right? It's not an easy fix. It's a very complicated thing to actually consistently get exercise in your life. So whatever the solution is, it's going to be complicated. It's not going to be straightforward. It's not going to be a simple fix.
While you have the microphone, the CSA is bringing awareness to comorbidities within the spondyloarthritic community. And the top 5 comorbidities experienced according to our recent survey of nearly 400 spondyloarthritic patients are depression, anxiety, chronic pain, chronic fatigue, and sleep. Can you please reiterate how important a proper mental health plan is to a patient outcome?
Yep. So, you know, we have this distinction in our culture about physical health and mental health, but really we exist as a whole person, right? And so it's always important to take care of your physical health, but also to take care of your spirit, right? And part of keeping your spirits up is to build a life that matters to you, even when you have the condition. And so sometimes focusing less on getting rid of your condition and focusing more on living a life that matters to you even when the condition is present, and how to problem solve living a life that matters to you even when you have the condition, which often involves a whole bunch of maintenance so that you can do the things that matter to you. You know, that is probably the way to have a more vibrant life. It's not getting rid of the illness. It's figuring out all the problem solving, how to maintain your illness and take care of it enough so that you can do the things that really matter to you in life.
I just want to add one thing to that. It's somewhat connected. I have my own microphone. One thing I think that is connected to that, I don't know if you would agree with this, but I don't know if you've heard of mindfulness-based stress reduction training, MBSR. It's something that I believe there's mounting evidence of its efficacy in dealing with chronic pain, and I would definitely recommend that to anybody here.
There's very strong evidence for mindfulness, so mindfulness interventions for pain. There's really good evidence for that. But again, it's not a simple fix, right? Doing mindfulness and practicing mindfulness as a regular practice is like doing exercise. It's, you know, it's hard work to do, and it's very effective. The studies show it's very effective for pain, it's effective for depression, it's effective for anxiety, but it's a bit like exercise. It takes that much kind of time and effort to do it on a regular basis. So it is a fix, but it's not an easy one.
And can anyone address the value of patient groups and what they could bring to the patient outcomes? Do you ever encourage your patients to attend a support group? Tell them about the Canadian Spondylitis Association, or sorry for putting you on the spot.
No, it's okay. The spot's a good place. So yeah, I think, you know, I fall short in a lot of areas, and this is probably one of them. I mean, it's you know, I don't want to, you know, start to say, you know, poor me or something, but we're so focused on kind of surviving and just, you know, that we don't probably deal with a lot of sort of value added to this things, right? And you know, in my job, I I sit down because it gives the illusion that I'm spending more time, or that I'm, you know, so that's kind of how strained, you know, I am personally. So I think sometimes you have to create an environment where people feel comfortable asking you their questions and whatnot, and so you know when you've created that environment, because the questions come, but I suspect I don't know when I've not created that environment, and how many questions go unasked. Oftentimes, especially in young people, right? If you're 80, you kind of have a different expectation out of life than you do when you're younger. And so if somebody's gone from healthy to non-healthy very quickly, you know, it's often very much a greater challenge, and they're comparing themselves to their peers who have absolutely no limitations. So, and the rarer the disease, the more alone people can feel. So, so sometimes I do ask them, but it's not, you know, we do have some pamphlets and whatnot, but I think it would to some degree require me to get inside that person's head and find out what it is that they're needing, and like I said, I know when I've done it, but I don't know all the times when I haven't done it. So it would be frightening probably if I ever learned that.
So I'll just add to that, which is it says a lot about humans as a species that solitary confinement is a form of punishment, right? What do we do to like the worst of the worst? We put them in solitary confinement and they don't like it, right? So it's really important to not put yourself in solitary confinement, to not isolate yourself, whether that's through a patient group or friends and family who get it, you know, or other forms of support, to make sure that you have an active kind of support network and socializing opportunities, because that's really healthy for us as human beings.
I just want to add one more thing to that. I think that there are different types of groups, like arthritis patient groups, and they all work differently for different people. So I think people think of support groups as I'm going to have to go in and sit in a circle and share my innermost feelings. That's not something that I've ever been interested in or engaged in, but volunteering as a patient with organizations puts me in touch with other people. So it's not so much needing to share with other people, but just being around other people that understand what I'm going through. And now I think, you know, the first thing anybody does when they're diagnosed with something is look it up on the internet. And you'll find all kinds of patient groups, and there's different ways to connect with all of those. You can do it, you know, just online. You don't have to ever go to a meeting or a group if you don't want to. But I think there's lots and lots of different things out there for people to.
What about, like, Chris, do you have a family also, like,
yeah.
and children?
Yeah.
How do you manage, like, work and your family, like, with the fatigue? Like, if you do the diet and you do the exercise, like, how does that all work out?
Well, it's taking care of myself is almost my full-time job, and then I have this other job that I have to do to bring money into the house, and then I have a job as a parent too, and it's exhausting. I mean, I'm lucky right now. I've been in a good phase for a long time. Dr. Bakowsky would say I'm in cruise control. I have flares and I have difficult times, but when things have been really hard, it's overwhelming. It really is. Yeah. I mean, getting to work and also taking care of your family is difficult. Yeah.
It's also about, you know, recognizing like what's important to you, you know, about like what kind of parent you want to be, what kind of person, if it's related to like working, what's important to you about that. And are there other ways of doing that, right? We get caught up in like, well, to be a good parent, I have to be throwing around the football with my kid, and that might not be possible for you, right? And so what are other ways that you could express that value of being an engaged parent, right? Maybe it's reading to your kid. Again, contributing to your household, like working, right? Is that because about contributing to the household through financial things? And so there may be other ways that you can still express those values, even if you may have some limitations about what you can do. And that our minds will always tell us it's not enough, right? It doesn't matter if you have this disorder or something else, or this condition or something else, our minds always tell us it's not enough.
Yeah,
there any support group for spouses? Or?
Yeah. Also talking about that. I'm sorry, we have to make that our last question. We've run out of time.
But if your question
Yes.
is online to questions@spondylitis.ca, we will actually email you the answer. So he's
Yes.
going to send them questions into
Yes,
the
so
app.
any more questions that you have, please do just address them to questions@spondylitis.ca, and we will do our best to get back to you with the correct answers. Okay? And I'd just like to do a quick summary again of the Canadian Spondylitis Association. We have been very active in raising awareness and providing education over the past year. We continue to hold information sessions like we have had today. They continue to be quite popular. And one of our focus for 2018 will be creating a series of webinars so that we can bring education to a broader community. Some of these will be live and interactive, as this one was today. Some of them will be recorded and posted on our website, so please keep a lookout and we will keep you informed about that. Some of the webinar topics will include things such as treatment options, private insurance, comorbidities such as depression, anxiety, uveitis, inflammatory bowel disease, cardiovascular disease, psoriasis, the importance of exercise, tips and practical tips for such things as fall prevention, traveling, smoking cessation, and life coping tips such as parenting and working. We continue to our peer monitoring. I will shortly be taking over the role of volunteer director within the organization. Anyone who is interested in volunteering can come see me today, or can, at this current time, simply email our executive director through the Spondylitis Association. And as the volunteer director, I will be placing volunteers in the positions that they are best suited. We currently have a need for translators, people who can assist us with proofing, peer support, social media, and fundraising, and any amount of time that anyone can volunteer is very much appreciated. We are also in need of local support group leaders, anyone who's willing to hold a group on their own or with the assistance of another person. You can, again, speak with me or contact our executive director. Support groups are a great way of meeting other people who are experiencing what you are experiencing. Like Chris has said, they are not for everyone. I've run a support group in Hamilton for 7 years. Some people come for just one session. That's all they need, just to ask their general questions when they're diagnosed, get some general information, and to just finally meet someone who actually has this condition that nobody's heard of. Other people have come faithfully to every meeting that I hold. Some of the people that I've met during the group have become what I know will be lifelong friends. And how wonderful to have friends who can actually identify with something that is so significant in my life. And I'm sure many of you would feel the same way. And we also, in the CSA, totally support bringing your friends and family to meetings, because we recognize that they seriously are affected by the disease as much as we are. And sometimes they are not given the support that they need. By attending meetings, they get support, and they are also enlightened to what we are actually encountering in our lives. And it gives them a bit better understanding on what you are dealing with. Our newsletter continues to be popular, and we'll be bringing a series of articles regarding comorbidities coming up this year. And this is something that you can share with everyone in your life, or they can also sign up for it themselves, educate themselves. Our website continues to be restructured. Our first stage is complete, and we will be adding new content and features. Please continue to watch us grow. Our Facebook community is growing. Currently, our Facebook group has over 1,000 members, people who are very supportive and engaged. And if you seek some sort of support and do not have a local support group, please do consider joining the Facebook group. And our Twitter continues to grow as well. And as far as advocacy, we are committed to bringing the voice of patients in an effort to ensure timely access to medications and services. and we are educated and share our position as it relates to important policy issues that currently impact or will impact Canadians in the future. Okay, you've heard the term comorbidity today. A comorbidity is not a symptom of our spondyloarthritis. It's a separate condition that we have secondary to our primary diagnosis of spondyloarthritis. This year, the Canadian Spondylitis Association is embarking on a big comorbidity campaign. We are going to make an effort to partner with other patient organizations in order to bring you the best information possible on quite a variety of conditions. And we also want to be able to bring you support available through these organizations. But in order to do this, we need your help. So if you have not already done so, please go to either our website or our Facebook page and take the comorbidity survey. We need your responses so that we can help prioritize the conditions that we will be addressing. If you haven't already done so, can we get the next slide? Okay. You can reach us on our website, via Facebook, our Facebook group, and we are also on Twitter. And if you have not already done so, please do sign up to become a member. Membership is free. It entitles you to our e-newsletter, regular information regarding events, and it gives you a voice within the Canadian spondyloarthritic community. I would like to take this opportunity to thank our wonderful speakers today. I've attended quite a few patient forums. I always leave learning something, and I think this one was particularly engaging. So thank you very much to all of our experts. I'd also like to thank all of you for coming out on this chilly Saturday morning and sharing your time with us. And thank you to all of you from around the country who joined us on this webinar. Thank you to our videographer, Chuck, and to our volunteer, Kyle. And I think we all owe a big round of applause to the unsung hero of today, and that is CSA Director and Halifax's own Gloria Boudreau. Without Gloria's incredible technical skills and her organization, today's event could never have taken place. And very, very quickly, thank you very much for being so accommodating in our last-minute change of venue. I hope you have a wonderful rest of your day, and thank you once again.
And thank you to Marilyn, who came all the way from Ontario.
Yeah, you're welcome.